with StraightSmile Solutions, StraightSmileSolutions.com, wishing you a Merry Christmas 2020. Actually, I'm not talking about Christmas today. I'm going to be talking about jumping an anterior crossbite. Just so happened to be convenient. It's also Christmas Eve. But I've been hesitating on making this video because sometimes when I make videos, I feel like they go to the wrong people that I intend to use them. So I'm going to speak intentionally at a very high level when I use the verbiage for this video, because it's really meant only for dentists, teaching them how to use a trick to teach their patients. I don't necessarily want consumers using these tricks and tips unwatched, unverified. So the power of YouTube is that you put something out there and you hope the right people use it and use it the right way. So docs, I'm going to be making this video for you. This is going to be a specific trick and tip that you can use on interceptive patients. Interceptive patients, meaning patients prior to phase 1 treatment. If you see something happening, you see an anterior crossbite developing, and you want to try to mitigate it. You want to try to do something that's free to fix it, so that hopefully you do not have to do like a spring retainer, Invisalign first, or anything like that, because you can do it for free. Believe it or not, if you catch it early, you can fix these things for free, assuming that the issue is a dental anterior crossbite and not a skeletal anterior crossbite. And if you don't know the difference, you need to watch my other videos or read my book at StraightSmileSolutions.com. Again, this trick only works if it's a single tooth dental anterior crossbite, not a skeletal anterior crossbite. That means if your maxilla is set back posterior, this is not going to work. You're going to need to do an expander, open the sutures, and do a protraction face mask. How are you going to know the difference? Well, you're going to have to take a ceph. So unless you take a ceph and get the numbers, and that's something we'll be glad to help you analyze. If you do that, you don't know. So this isn't meant to be for someone just to wing it. And if you do this incorrectly, or you put too much pressure on it, and you do this unsupervised, you might lose the tooth. So this isn't something that you should be doing unsupervised, willy-nilly, or anything like that. So what do you need in order to fix this? First of all, again, this is pre-interceptive, 5, 6, 7, 8-year-old who maybe is starting to get number 8 and 9. It could be 10 or 7 or 10 as well, but it's usually 8 or 9 when it comes in and it's starting to hit the lower teeth, which have already erupted as an interference, and it's colliding. It's not really meant for something that's in a full crossbite. It's meant for something when it comes down and it bangs on the lower tooth and it just stops erupting, So maybe it's like 50% in and it just stops there. And eventually it's going to go one of two ways. It's either going to slide forward or it's going to erupt, or slide back and erupt. And most likely it usually slides back and erupts. And then once it does that and erupts fully, you are going to need phase 1 braces, or you're going to need phase 1 aligners, Invisalign first, and that gets a lot more expensive. So if you can catch it at an early stage when it starts to happen and jump it in a free way, then you don't have to pay for all these lab fees. So cool, awesome, right? So, I always worry about doing this with my patients because I want to teach them this trick, but then again, I can't really bill for it, right? Because it's not an appliance, it's not braces. So this has got to be on someone that you're cool to help out, but it's not official treatment. So it's a little bit of a gray area. So you got to watch out in terms of paperwork, liability, and all that stuff. So best to be using this on your friends and family or things like that, and maybe not a patient that you don't know that well, just because it could go wrong, right? So all you need in order to do this is a tongue depressor. Actually, my favorite is a waxing stick. They're plastic, because tongue depressors taste disgusting. If you've ever sucked a popsicle stick, a regular popsicle stick is too narrow. So you need the nice wide tongue depressor. This is a waxing one. You can buy them. Unfortunately, you can only pretty much buy them in bulk from Amazon or eBay that I found. You might have them in your office. I always had them in my office, just, to do a quick retract if I didn't want to sterilize something and throw it away. I know it's not sustainable, but we always had them. But this is just a waxing one. It comes with any microwavable wax or that you buy from Amazon. So get it. Obviously you want one-time use, and patient needs to, again, this is for interference crossbite, dental crossbite, non-skeletal crossbite. Patient, let's say it's on number 9. Is this 9? I'm backwards. So I don't even know what tooth that is. Is it 8? I don't know. One of these front teeth. And let's say as a kid, I was like this, right? Just bite down. Bite down. That's all you do. Have them bite down and hold. They can't just rest it there. They have to bite down and hold for about 5-10 minutes at a time, 3 to 4 times a day for a couple weeks until it jumps. So they need to bite and hold. And they'll, kids are hard because they're going to bite, but they're not going to hold, right? They're just going to rest. So they need to bite and hold, squeeze. They can squeeze, relax, but 10 minutes at a time. put on an egg timer or something like that, let them watch a game, let them watch a movie, and bite and hold and bite and hold. It will work if they do it, as long as it's the right kind of case selection that I mentioned, and it should come forward. And as long as that's the only problem, it should resolve, you know? But of course, if you've got crowding and underdeveloped arches, you're still going to have other issues. So you need to pick your case wisely. Anyways, hopefully that was helpful. I hope it was really, really helpful for you. As always, you can reach out to us at StraightSmileSolutions.com. Take care. Aloha. Hi, it's Dr. Amanda with StraightSmile Solutions. We're here today to talk a little bit about biotrainers, myofunctional appliances, and phase 1 appliances, and how to incorporate them into your practice, how to incorporate them into your phase 1 treatment, how to incorporate them into your phase 2 or comprehensive treatment. And I'm very, very honored that Great Lakes Dental Laboratory has picked me to do a series of videos, educational videos on their biotrainers to help train orthodontists, general dentists, and pediatric dentists for indications of use. And I'm going to be working my way through their series of appliances and telling you more. I have seen a lot of great outcomes with these appliances. This is, I believe, a European-based company, and it's being distributed by Great Lakes in the US. If you have any questions, feel free to contact me, and I'll be glad to talk to you more about phase 1. I have a great monograph or phase 1 quiz that I kind of created, which will help you screen patients and to see if they need phase 1. So I'm glad to send it to you. It's called My Phase 1 Smile. Feel free to email me at info@straightsmilesolutions.com or visit my website at straightsmilesolutions.com, and I'll be glad to just give you a copy. I'll just give it to you. It's free. So I'm just glad to be helping people, and that's my ultimate goal. So today we're going to be talking a little bit more about one of the series of appliances, one of the first appliances in their series. It's called U Start. Letter U, Start. Indications for use are age 4 to 6, okay? So we're thinking either primary dentition, full primary dentition, or very, very early mixed dentition. I would probably discontinue this appliance once the 6-year-old molars came in. So we're thinking like age 4 to 6, maybe 4 to 5. Once the 6-year-old molars come in or the first few front teeth start to come in, it's time to move on to the next in the series of appliances. I'm going to be giving you all kinds of gems and tidbits about phase 1 treatment and how to use these appliances, how to bill for insurance. There's just so much information I can tell you, and it's something that we work with our clients with all the time. So thank you so much to Great Lakes for giving me samples of all the appliances. I'm just going to kind of verbally tell you what I see and feel, and you can see them. So this is the U Concept appliance, the U Start. Again, it's for age 4 to 6, okay? This is just me saying, I would probably discontinue and move on to the next series once the 6-year-old molars come in. These are not custom, okay? So that means that you can just order them, you can stock them. The prices are very reasonable. You may or may not get a discount, a volume discount if you choose to stock them. Is this all you need for phase 1? No, not necessarily. So phase 1 is interceptive treatment. You're getting the kid from A to Z. For me, you don't discontinue phase 1 until 6-year-old molars are fully in and front teeth, top and bottom, are aligned, you know, and as well. And the arches are formed. So, you know, it might be a part of the phase 1 process. Maybe this is all they need, but it's probably pretty unlikely. So some of the features that I recognize in here is basically you've got it's real soft, if you can see how I can just touch it. So I think it's gonna be very comfortable. It does come in 3 colors, clear, which is nice because you can see the teeth easily through it, as well as pink and blue. So you can choose what colors you want. It has some eruptive guidance features on the inside, like little imprints so as the teeth start to come up, they're gonna bounce off the wall and come a little bit straighter. They also have a firm version, which is a little bit more rigid, that only comes in clear. From my experience, those are good if you have a bruxer. Maybe you want to start with the soft. It's going to be much easier for the child to get used to wearing it if you start with the soft. And if you start getting bite thribs, then that's something you can move on to. What else? So I see other features in here that are good. Basically, it's going to work for any patient that has up to a 6mm overjet, as well as a slight class 3 patient. You have to move on to a class 3 appliance if you do have a class 3 patient, but this is a good way to start if they're in early mixed dentition or in primary dentition and you start to see some anterior crossbite. You're probably going to get a little bit of arch expansion, but I don't think you're going to get too much with this. I mean, it is pretty soft. Maybe if you need more arch expansion, you'll want to move on to the more rigid one, or you'll want to go into a Schwartz or some type of expander. And feel free to connect with me on that. I have tons of YouTube videos on that. Looks like we also have a little place, I call it a pillow, for the tongue to rest so that the tongue doesn't go down. It remembers to swell up at the roof of the mouth. So just some tips on delivering this appliance. Initially, a good way, you don't just say, give it to the patient and say go, okay? So it's gonna take some time, especially if the patient is a mouth breather, it's gonna take them time to get used to wearing this. And we wanna take baby steps. So I usually tell patients, hey, first night, why don't you try to wear it during one cartoon or, one video game or something like that, or while we read a book to bed. And then the next week you can move up to a movie or while you do your homework. And eventually we're going to try to wear it all night long. Now, some patients might take a few weeks to keep it in all night long. Some patients might take a few months to keep it in all night long. Over time, the mouth is going to grow the musculature to be able to retain the appliance. And the nasal breathing is going to help the patient significantly. So remember, if the patient has a cold or something, this is not a good time to start this appliance. We want to have patent nasal breathing. So if you need to address that with some allergy spray or something like that first with the child's pediatrician, you definitely want to do it. Also, let's just get into this. You need to be screening your patients well. You can't just give this to a patient because a patient that maybe has swollen tonsils or nasal or oropharyngeal airway blockage, this is not a good indication for the patient. Although this might help the patient, you want to make sure you're working with the child's pediatrician if you are screening Malampati, tonsils, stuff like that, and refer out as needed and collaborate with the pediatrician or the ENT. And I'm glad to give you some guidance around that as well. So again, this is the U-Start appliance for age 4 through 6, primary dentition or early mixed dentition. It does come in 3 colors, pink, blue, and clear in the soft. And if you move up to the rigid, it only comes in clear. You can order these from Great Lakes. Glad to tell you more. You can go ahead and visit my website at StraightSmileSolutions.com. Keep those questions coming, and I would love to see your cases if you start using them. Again, this is part of the phase 1 process. So things you can bill D8060, D8050, D8210, I believe. So depending on how you're using it in your practice. So we can get more into that, and I can send you more information on that. Those are ADA codes for the US. All right. Hi, it's Dr. Amanda with StraightSmile Solutions. Today we're going to be talking about myofunctional products and how you can incorporate them into your practice. It doesn't matter whether you're a pediatric dentist, a general dentist, or really any kind of dentist, or even if you're an ENT or a pediatrician and you want to learn more. I'm going to be talking today at a high level about 4 different products that are out there on the market in the US and Canada and abroad. I have personal experience with all 4 products, and I'm going to be talking about a very high level about the options that are out there. If you are the CEO or the owner of any of these 4 products and I said anything correctly, please reach out to us at StraightSmileSolutions.com so that we can go ahead and update this video. This video is based on the knowledge that so far I've obtained in clinical practice. The 4 different products we're going to be talking about today are MRC or MyoBrace, Healthy Start Orthotane, Vivos, and U-Concept 7Cs. Okay, so let's go ahead and start. Number 1, MyoBrace MRC. This company was founded about a decade or 2 ago in Australia, and it's a very kid-centered product. For the most part, they really only work with kids. The one thing I like about it is that they have really kid-friendly exercises that you can go ahead and learn how to do. And you can become an actual sponsored MRC office. You do need to take a course in order to be certified, and at the moment I believe all their courses are destination courses. They're available in Australia or in California, and sometimes they're available elsewhere. Price point on their appliances is relatively reasonable. Last I checked, it was somewhere in the doctor-facing lab fee, by the way. And these are Class 2 medical devices. It's somewhere in the neighborhood of around $70 to $90. Sometimes cheaper if you're buying in volume. You do need to prescribe these appliances to your patients. They do have a lot of wear though, and their tooth-borne or eruptive guided appliances aren't the best. So there's a lot of grinding or issues with show-through or breakage of these appliances, so you may need to replace them often. Patients are going to be, in order to get success, patients need to work through a series of exercises, and you need to train up your whole team on learning how to prescribe these exercises, and it's a very compliance-based product. Ultimately, I think it's a good product that's out there and something you should definitely consider if you're willing to put the work in to learn how to integrate your practice. The second one I'm going to talk about today is Healthy Start by Ortho. I have lots of favorable things to say about this product. I specifically really like their habit corrector, and I like that you can stock the habit corrector in your office up front. You do need to be certified in order to become a doctor with them. The course is a couple $1,000s, and with that course I believe you may get a discount or get 1 or 2 free cases. Things might change, so you can go ahead and ask them. The other thing that's really nice about their appliance is that, first of all, they've been around for, goodness, I think about 40 years. So they have a lot of cases under their belt. You can ask them exactly how many. I have personally seen a lot of very favorable outcomes. The best way to get started with Healthy Start is to start young. It's a marathon, not a sprint. So if you're with the patient for a long period of time, there's a chance that the patient may never need braces if they start early with Healthy Start and they are compliant. So that takes about 7 years though. So like I said, it's a long-term commitment. And sometimes doctors have a hard time getting patients to stick with the product. But I've seen very favorable outcomes as long as you start early and the patients are compliant. Sometimes if you want a more favorable outcome, you may need to expand your patient first in an actual expander. And they can tell you more about that, or you can refer to some of my videos on how to use a Schwartz expander. Like I said, it does cost a couple $1,000s in order to become certified. So, and you may or may not get a free case or 2 with that. And I believe they have both digital and destination courses. Lab fee for these, the habit correctors is a little less than $100, and you can stock those up front, although they are a Class 2 medical device. But in order to get your hands on one of their really awesome appliances, which is their IG or G appliances or their N appliances, you do need to not only be a provider, but you have to also register the patient. I believe price point on those treatment plans with the series of appliances is around $600 to $800, so it's a big commitment. And it's totally compliance-based. So you need to make sure you pick the right patient in order to have success. Sometimes you're going to need to finish up in a few express or easy aligners or some braces at the end, or you might need to do some expanders at the beginning. So you need to have some basic orthodontic knowledge, I think, in order to have good success with that product. But they have very favorable outcomes. Third product I'm going to talk about today is Vivos. This is the one I know the least about because they haven't allowed me to take their course. All the other products I've had really great interactions with their team, and I'm very familiar and I've seen a lot of outcomes. Vivos is a relatively new product, and it's very, very expensive to join their network. I believe it's around $50,000, 50000. They have not allowed me to take their course, neither their pediatric course nor their adult course. And I'm certainly not going to invest $50,000 into taking their course. So it's one of those things where you need to be like all in with Vivos. You also have to own some technology, some very sophisticated technology so that you can read airways. To me, it doesn't make sense to take that course if you're only focusing on kids, because it's only a small section of what they do. And their products are very similar, their kid products, to what the other products are out there, and their courses are a lot cheaper, if not free. So that doesn't really make sense. But if you're looking to do more OSA or adult OSA correction, then maybe that's a course for you. But again, I haven't seen it. It's a little bit interesting, and I don't want to say anything negative in this video, so I'm not fully on board with it yet because, again, I haven't taken the course. So that's all I can say about that. Big investment, quite a big risk, but some people swear by it. Ultimately, I've seen a few finished cases, and I don't love the outcomes. Basically, what it's going to come down to is that, yes, you may improve their OSA and get them off the CPAP, and I think that is awesome if you can do that, but you might jack up their bite in the meantime. So you need to go in letting the patients know that their bite may not be as good, but their airway might be better. So that makes sense to me as long as you pick the right patient. But again, huge investment. Lastly, I'm going to be talking about 7Cs or U concept. This is a relatively new product in the US and Canada. It's been available in Europe for over a decade. I've seen a lot of great outcomes with this product. The thing I like about this product is that the price point to get started is $0. It doesn't cost anything at the moment. So subject to change according to the team at Great Lakes Orthodontics, who has the distributorship for the United States. price point on their appliances is less than $50, so there's really no risk there. I like their appliances because you don't have to take a class, but you do need to understand orthodontics in order to do this. So I highly suggest that you listen to a lot of my videos that I've made about their product. I love that they're very friendly with me and they let me sample all their products and talk about them. So check out all the videos I've created on their products. For example, this is one of their little kitty products. I believe this is the U Kitty. This is meant to be a way to help to eliminate pacifier and thumb habits in kids as young as age 2, 3, or 4. And if you eliminate these habits easily, often the bites will correct on their own. These are all BPA free and ISO certified Class 2 medical devices, and they come in a variety of different colors. In addition, they have products going all the way up to teenagers that help to correct Class 2, Class 3, myofunctional exercises, myofunctional products, tongue thrusts, improve sleep disordered breathing, and they also have products that can be worn over braces and aligners to help to correct Class 2 and correct OSA issues. So I'm super excited to tell you more about that. Definitely check out the team at Great Lakes Orthodontic Laboratory if you'd like to learn more, or you can reach out to me. All right, thanks so much. Send those questions more my way, StraightSmileSolutions.com. This is Dr. Amanda from StraightSmile Solutions, and today we're going to be talking about fixing overjets, or as some people call them, overbites. Really, an overjet is where your front teeth are ahead of your lower teeth, or your lower jaw might be a little bit small, different ways of describing it. So let's talk about the best way to fix this. And the reason why I'm launching this series is because I get a lot of questions from just consumers, parents who just don't understand. Like, they're getting different recommendations from friends, from other doctors, from orthodontists, from their general dentists, and they don't understand what's best. And yeah, it's really confusing. So let's just get kind of the straight story on what the different options are, what your doctor might be telling you. And I can't say what the best way to fix a child's bite is without, examining them in my office. But in any case, I just want to explain the different options to you so that you have the power to ask the right questions. Okay, so here in this infographic, you're going to basically, it's just saying, is it better to do appliances or is it better to use rubber bands? Of course, another option might be jaw surgery, but that's way down the road. Nobody wants that. So basically, there's going to be two main camps in order to fix this. So camp number one is who I describe as the doctors or the parents that believe in early skeletal correction. Now, I know that sounds weird because I'm saying skeletal. That's not a skeleton. It just means finding the source of the problem. And if the source of the problem is having a jaw discrepancy, like the lower jaw just genetically didn't grow appropriately to the right size, this could be genetic. It could be environmental. It could be the way a child slept or habits that they have, resting their hand on their chin in class, lots of different things. Thumb sucking, lots of things can hold that jaw back, okay? So what we're saying here is maybe one option is to go ahead and stimulate the growth of the lower jaw to correct the bite discrepancy while you still can, while the bones still have that genetic predisposition to, it's a big word, to grow correctly. So that's early skeletal correction. And that's one camp. A lot of orthodontists are totally in this camp. A lot of pediatric dentists are totally in this camp. A lot of pediatricians are totally in this camp. It's natural. It's healthy. It's the way it's meant to be. Of course, I'm a big fan of this. You can hear me talking about it. This usually must, though, this is the key, must be done between the ages of around 6, 7, 8, and 9. Could be 5, 6, 7, 8, 9, 10. But you really have to dial in to the skeletal maturity of the child. You can check with the pediatrician. There's a lot of indicators for skeletal growth. This could be a whole nother series, how to find this out. You can read x-rays, you can read hand-wrist diagrams, you can read the cervical age, the age of the bones in the upper part of the backbone, so many different things that you can do. Okay? Option number 2 is to wait until the child's in regular braces, comprehensive braces, or aligners, and to fix it with rubber bands. Could be rubber bands, could also be something like a Jasper jumper, a Herbst, all kinds of little piston-y devices, Amara, all different synonyms for this, okay?
But basically what we call this is dental alveolar correction. And basically that's a fancy word of saying we're tipping the teeth to make the teeth match up. We're not fixing the jaw, we're tipping the teeth, okay? So we're leaning the lower teeth forward or pushing the upper teeth back to get them to match up better. Overall outcome, I'm not going to say it's the same because it's not the same, but the overall outcome is yes, the bite will appear corrected, it'll function correctly, but how it got there is different, and the way it may look on your face when you turn a profile view may look different. Maybe you like that look, maybe you don't like that look, but I think you have to understand the difference. Because if you wait too long and decide to go with the late dental alveolar correction, too late, where maybe the girl has already finished her skeletal growth, this could be as early as age 8 or 9 in a girl, where you're already outside that window where it's possible to get skeletal correction. And your only choice now is either dental alveolar correction or a jaw surgery. So it is not much you can do in that case. So that's why I think it's important that all parents, when we start to see a discrepancy in the bite, are given options. And I really, really encourage every single general dentist and every single pediatric dentist and every single pediatrician to educate themselves on what the different options are so that they can give each parent a choice on how they want to treat their child and what the risks, benefits, and alternatives are. That's pretty much all I wanted to say here. We can dig more into this later if you want to talk about rubber bands, you want to talk about the different appliances to correct bites. There's so many different appliances. All of them work slightly differently, but all of them are just about the same, ultimately. So fixing bones or tipping teeth.
Hey, it's Dr. Amanda with StraightSmile Solutions, and today we're going to be talking about the My Phase 1 Smile Index. It is like a little screening questionnaire that we created about a year ago. It's something that we give out to our clients with StraightSmile Solutions. Anytime they ask, we support them to use this. If you are not a client, we will be selling it, kind of like an ebook, for a small fee. How you choose to use it is how you choose to use it. Basically, it has about 2 pages of screening questions, and it'll automatically calculate the points. At a certain level of points, it's strongly recommended that you start with phase 1 treatment on the patient once the patient is 7 or 8. The lower the points, the less crucial it is. It's not always cut or dry with phase 1. It's just a recommendation. As you've seen my other videos, you know that the goal of phase 1 is to set the patient up for success so that, there's always a chance with phase 1 that you might not have to do phase 2 or that it won't be medically necessary, at least. If you get the bite just right, the arches expanded the way they're supposed to be, grow the jaw to the way it's supposed to be, then often you don't need to do phase 1, or at least there might be some very minor, rotation, something very cosmetic that could be optional at a later date. So the goal, of course, with phase 1 is to get the arch width ideal so that the teeth have space to be successful and grow in. If you build it, they will come. To, of course, grow a maxilla if it's underdeveloped, grow a mandible if it's underdeveloped, improve the airway. Of course, cosmetics is an issue as well. Function, the ability to properly eat, bite, and stuff like that. Eliminate habits, everything like that. So we've always given out this index to any of our clients as just a part of what we do. If you're not a StraightSmile Solutions client and you'd like to try this index, we will now be basically selling it like an ebook. So you can just purchase it. No instructions, basically use it as you see fit. If you'd like to have some tutorial or some instructions behind it, we are glad to teach you as well. And we'd be glad to talk to you a little bit more about that. So let's talk a little bit more about phase 1. We've already talked about it a little bit. Here's some of the price points that I recommend for that, for your practice. If you're going to do phase 1, most likely you're going to need a second phase 2 later. Whether you choose to keep the phase 2 in your house or not, in your office or not, you can always decide that later. I love the idea of pediatric dentists doing phase 1 because it's a small commitment that you can handle. And then later, if everything comes in like you planned really well, you can always do the phase 2 later. Remember, insurance is probably only going to pay once. So if you wipe out the insurance in phase one, there's no bigger way to piss off a parent than all of a sudden telling them, by the way, you owe me $5,000 for phase two. You know, by the way, insurance is going to cover that. They will be furious. So you need to be really, really clear with the patient, with the parent. If you're going to use the insurance now in phase one, it might cover the whole thing or most of it, but later they're going to, if they need phase two, which is likely that they'll need something, need in quotes. It may not, maybe a little bit more cosmetic, less functional. It may not be something they have to do immediately, but most likely they're going to need a little bit. And it could just be a few express aligners, but we can't predict the future. All we can do is set things up for success. So in comparison, comprehensive is one go, do it all in one go. But remember, right now with phase one, you're trying to harness the growth during the pre-pubertal, pubertal phase. And this can happen in a girl at 8, 9, 10, and often does happen by 9, 10. And they may only have 8 permanent teeth in at that point. So you really now more than ever need to be doing phase one so that you can harness the growth. If you wait for comprehensive until they're done growing, you're not going to get a good outcome. So it's really important to understand that and understand growth a little bit more. Here's some of the options that you can do in terms of appliances for phase one in your office. You don't have to do them all, but these are just suggestions. Expanders come in all different forms. Myofunctional trainers, distalizers, ways to upright teeth, habit appliances. I'm not a huge fan of headgear, not this kind of headgear, but I like the protraction face mask that moves the upper jaw forward. That's great for class 3. That works really well. And growth modification devices. I mentioned the My Phase 1 Smile Index. That is something, again, if you contact me before Sunday evening, tomorrow, I'll be glad to email that to you. You'll need to email us directly, and you can go to our website to do that. And I will send you a copy of that. Normally, there's a fee for that. It's a free screening form that is used by our clients, but I'll be glad to give it to you. And actually, I thought it was going to be on my page to upload, but it didn't show up. So same thing with our hand wrist x-ray analysis form. We created this. We found an easy way that we just created on our own. This is copyright. To be able to screen your patients, to know their growth. Super awesome. A lot of pediatricians love our form, and it's something that you could actually bring this if you wanted to your pediatrician. What a great way to network and to get more clients. We've talked a lot about phase one, expanders, different types of expanders, RPEs. Great way to develop the arches, to fix certain types of bites, deep bites, open bites. And you can even build all kind of bling in them to help with overjets. To correction, okay? Overjet correction. We're going to be talking about twin block therapy. And twin block is a key appliance I like to use in growing kids. Now, if you want success with this appliance, and this is the lower and this is the upper, okay, you need to pick your patient wisely. By picking your patient, first of all, you need to pick a patient who has overjet, of course. I'll show you like a good patient. Okay, so this is what this patient looks like. Okay, this is a great patient for twin block therapy. Half to a full cast class 2, growing patient, has overjet, in mixed dentition, not permanent dentition. What else? In terms of skeletal maturity, you need to do a skeletal maturity assessment, okay? So that means you need to measure and make sure your patient is still growing. How do you do that? You can't just guess. You can't just say, are you still growing? Because this thing is not going to work. And this is going to be a complete waste of time if you do not choose wisely. So the best way that I like to do this, and you can ask a lot of questions, but is to go ahead and do a hand wrist analysis. And I've done a separate video on this. If you have a ceph plate, it's very easy to do. If you do not have a ceph plate and you can't do this, then you're going to need to ask a lot of questions about skeletal maturity, where they are in the puberty process. They need to be barely started, on the early end, not already completed. They shouldn't have had their menses. They shouldn't have their voice changed. They shouldn't have anything like that. Not even close, okay? If you want this to work well. So also let's talk about psychosocially, what is the ideal patient for this? So I don't like to do these kind of appliances that can be a little bit bulky in a patient who is in junior high. They need to be still in elementary school. So you need to ask the questions. Don't assume because they're in 6th grade that they're in elementary school. They may be in middle school. So this is best in a 3rd, 4th, or 5th grader, okay? Even 2nd grader, any of the above. You can do this very young. It is not at all going to work in junior high because you can see how bulky, I mean, even though from the front, you can barely see it. You know, this is what it looks like from the front. So that part is nice, and it is in 2 pieces, unlike your BIONATORs and your Frankel 2s and other things that are in 1 piece and really affect speech. But it's still a little bit bulky. There's some acrylic blocks on it, and vertically, you know, they're going to be talking and their speech is going to be a little bit different. People will notice, people will be asking what's in your mouth. They can practice, they can probably get 90% improvement with speech, but people will still know. And it kind of gives you a little bit of a long face appearance. So even though this isn't permanent in junior high, it's just not going to get worn. It's not. I don't care how great the kid is. It's just social suicide. So pick your patient wisely, right? So we said mixed dentition, just starting puberty or early in the puberty process, 3rd, 4th, or 5th grade. Skeletally hasn't gone even close through puberty left yet. And we're going to leave this in actually about a year, 9 months to a year. It's going to be in a pretty darn long time. So you need to make sure it fits well. As new teeth come in and out, you have to be ready to adjust it as needed. Okay. So that's pretty much how it works. You're going to go ahead, take your impressions or your scans. You're going to ask for a twin block. These little acrylic blocks, okay, are going to keep the mandible positioned forward. So you can see how they're going to have a little bit of an open, you know, open mouth like this. It's going to give them a little bit of a different look. They're going to talk a little funny. But this constant forward position of the mandible does encourage the a deficient mandible to grow over time. It's not just smoke and mirrors. It actually will grow if the patient does wear it. That means 24/7 for about 9 months to a year, okay? If they don't wear it 24/7, 9 months to a year, it's not going to work at all, okay? So then it's a waste of everyone's time. So of course, like with anything, I tell you, make sure you have your compliance paperwork in check. Make sure you've created a compliance program. If you don't know what this is, feel free to connect with me. This is something that we do routinely with our concierge patients, concierge clients. We help you set all this up so that you can do removable appliances and not get dinged if the patient isn't compliant. Like you have all your systems in place. Of course, you're not just gonna let the patient go either. You're gonna be having them check in. You're gonna be measuring the overjet and making sure it's working. Within 3 months, if you don't see a kind of a noticeable change, they're not wearing it. So you might as well discontinue it, you know? So that's pretty much it. If the patient has a deep bite, you might need to do some modifications. That means you're probably gonna want to draw off some of the acrylic behind the block right here, or some of the blocks behind the curved part, okay? So that the lower teeth can start to gently extrude. Same thing, you might want to take off a little bit under here, okay? And maybe even reduce it a little bit forward of the notch here. So slowly it can start to level out. But for the most part, this is a great appliance. If they do wear it for that 9 to 12 months, you can anticipate 3 to 4 millimeters of jaw growth, which is a pretty sweet class 2 correction. And the rest you can always get with elastics later in your braces or aligners. So this will reduce to eliminate, if you start early, the need for a jaw surgery or tooth extractions. So that is the why behind the twin block. Hey, it's Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today I'm going to talk to you about BIONATORs. And BIONATORs are definitely one of my go-to appliances for kids in the mixed dentition, kids with large overjets. The cool thing about BIONATORs is that they can be customized, not only in terms of color, you know, so the patient feels like that they can design them, but also for various bite issues, whether, you know, you're trying to open a deep bite, try to close an open bite. For the most part, BIONATORs are used to advance a mandible. So I'm a huge fan, if you've heard my other videos, about forward orthodontics, not moving things backwards, like say a Carrier or a HEADGEAR or a distalizing appliance that's backwards. So to fix an overjet, if you're doing backwards orthodontics, you're taking the top jaw or the top teeth and moving them back. We don't want to do that. So especially if we look at a patient and we're looking at their profile and we're like, dude, this person has a really tiny mandible. We're looking at the ceph, maybe we're looking at the airway thinking we need to do whatever we can do to open the airway, advance the mandible, not close the airway by retracting the top teeth or the top jaw. So that's why I love BIONATORs. They're also very simple. Like I said, very easy to customize both in color and in design to get what you want with the bite. Of course, they're 100% compliance based, right? But timing and picking the right patient with the BIONATOR is really critical. They just do magical stuff as long as they're worn. And they really do need to be worn 22 hours a day, usually for, I'd say, 9 to 12 months. So picking the right patient is key, explaining the why behind it. If they're only wearing it at night, it's not going to work. So they have to actually wear it to school. It is a one-piece appliance. So like I said, these things have been around for 100 years. They're definitely much more sophisticated, but there's different versions of them. They call them activators. There's all kind of trade names, but for the most part, they all lump into a classification of a mandibular advancement appliance, and I call them BIONATORs. BIONATORs are the most generic version. You can order them from any ortho lab. You don't have to take a special class or anything like that. Lab fee is probably in the neighborhood of 200-ish, depending on how much you bling it out. Like I said, it's a one-piece appliance, so you can figure if the patient's wearing it doesn't hurt or anything like that, but it's going to be a little tricky to learn to talk with it in because it does need to click in. It's being made with the lower jaw set forward, almost like the way, if you know Invisalign, their mandibular advancement version, it's similar to that. Now, this is going to work way better, especially in mixed dentition, than their MA. But you want to do this when the patient is ideally still growing, actively still growing, or prepubertal even, 8, 7, 8, 9, 10. You're probably not going to have a lot of success. And I encourage you to ask a lot of questions as to where the kid goes to school, what grade they're in, what does the school district look like in your area. Once that patient's getting into junior high or middle school where they're around older kids, forget it. It's not going to get worn. I can tell you it's not going to get worn. Because obviously it's going to work great in second, third, fourth, fifth grade, sixth grade, depending on what school they go to. But beyond that, don't bother. You'll need to move on to something else. But yeah, it can be definitely a phase 1 appliance, or it can be part of your comprehensive treatment. You do this first, and then once you've had some jaw growth, then you can go ahead and put the braces or the aligners on. Or you can even move into Invisalign MA, and finish the treatment up with that.
Hey, this is Dr. Amanda here from StraightSmile Solutions, and I had some questions about sagittal expanders, or you can call them sagittal distalizers. So sagittals basically are very similar to an expander. They work exactly the same way in functionality and in mechanism, but basically it's a jack screw that's built into a removable appliance, not unlike a retainer, that can help to distalize a posterior segment of an arch. So for example, here you see maybe there was an early loss of a tooth and the space collapsed. Maybe there's a blocked out premolar. So you can see the jack screw that's right here. And the idea is that we're going to go ahead and deliver this appliance before we do braces or aligners, or maybe just only for this reason, maybe as a phase 1 kind of appliance or an interceptive appliance, to go ahead and distalize the posterior segment to open up space for the new tooth, or to open up space for an implant or a bridge. Okay, so it works fundamentally the same way. You can get, I would say from my experience, up to 2 millimeters of space back. That's a lot of space, right? The way I deliver it is I go ahead and deliver it. Usually I'm going to do about 1 turn a week on the appliance, and please follow my instructions from my expander videos, my RP videos on how to do a turn. I'm not going to go over that today. If you don't know where that video is, you can message me and I will send it to you. It's in my library. You can search under RPE and it should come up, okay? But you're going to go ahead and turn in the direction of the arrows. Do it at nighttime before bed. Have the patient wear it. They do need to wear it 24/7 in order for this to be effective. That's pretty much it. So you're probably going to end up doing, ultimately you're supposed to get 0.25 millimeters per turn. So you can do the math. You're always going to lose some space. So you're probably going to end up doing, you're going to have to turn probably 30, 40, 50% more than you think you need. 15, 16, 17 turns. It's going to take a few months to open this up. What you're going to see is this segment distalize first, okay? And then if there's other teeth, they're attached to the PDL. It'll start to come out with it. So anyways, that's pretty much how it works. I'm excited to show you sagittal. I do use them regularly and I recommend their use. And I think it's an easy way to get improvements without having to do fixed braces or to make your fixed braces easier.
And the big question today that I get asked a lot is headgear bad? Does headgear work? Why are some orthodontists using headgear and some orthodontists refuse to use headgear? So let me tell you a little bit about headgear and what it has been used for historically and how things are changing now. How orthodontists and dentists and even pediatricians are thinking way outside the box and realizing that there's better ways to meet these objectives. So historically, headgear has been around for hundreds of years. Headgear is basically, in this case, I would call this quote unquote neck gear in this picture. I know that's not what we call it. In orthodontics, we call it cervical headgear. That means goes around your neck. There's also different forms of headgear. There's ones that go over the top of your head. And don't mind me, I used to love headgear. I used to do it all the time as an orthodontist. I loved it so much that when I was 8 years old, I made my own headgear out of paper clips and now and laters, and I wore it to school because I wanted headgear so badly. So the fact that I'm even talking about this to thousands of people all over the world is pretty cool. Because you know what? Let me tell you all about headgear. Let me tell you how I'm a reformed headgear orthodontist, and I would never, ever, in most situations, use it now, and why. So headgear is used for overjet. Overjet is what patients often call overbite. It gets confusing. Two different terms. The way you all use them and the way orthodontists use them is different. So I'm going to speak your language today, and I'm going to say when the front teeth are more ahead of the lower teeth, okay? So when the top teeth are more ahead of the lower teeth, we want to try to get the jaws to match up a little bit more. Why does this happen? It could be all one of many different reasons. It could be genetics. Maybe overjets, small lower jaws run in your family. Okay. Well, some people say you can't change nature, but you totally can if you start early. So the earlier you start with these things, the better. I'm talking like 4, 5, 6 getting started. I'm not talking 12, okay? So you do not need to wait for your family dentist to refer you to an orthodontist to get these problems addressed. If your family dentist is not referring you, you are welcome to make your own appointment with a friendly orthodontist near you. And if you don't get the answer you're looking for and it's not feeling good in the pit of your stomach, first of all, you're welcome to reach out to me at any time, StraightSmileSolutions.com. You can go to my webpage. You can go to the patient webpage and just get tons of information about different topics. You're also welcome to ask questions. I'm not a substitute and my team's not a substitute for medical advice, but we'll tell you not about your own particular situation, but we'll tell you about different options out there and how they're used. And we can also help to direct you to a very friendly orthodontist near you who specializes in growth and development and believes in airways and believes in correcting bites the right way. And we will find you that orthodontist if you need one. So don't worry about that. Give us that job. We don't earn any commission for this. This is just a gift that we give to the community to help you out because we believe in this. So let me digress. Let me go back to headgear. Why is headgear quote unquote bad? Because what it's doing is it's pulling those top teeth and restricting the growth of the top jaw, which is your maxilla. Well, your top jaw or your maxilla is extremely important. It's connected to your airway, your nose, and all of that. So if you're restricting the growth of that, a lot of not so good things can happen long term with the growth of your face, the shape of your face, the amount of air that can go in, the space for your tongue to go so that you can swallow correctly. This can affect all kinds of health issues later, okay? As well as the way you feel, the way you sleep. So we as orthodontists collectively, many of us are evolving and we're stepping away from using headgear to fix an overjet and we're moving towards all sorts of other systems to correct it that don't involve restricting the growth, that actually encourage, go think the other way. If you have an overjet and your upper jaw is ahead of your lower jaw, let's encourage the lower jaw to grow instead, right? Everybody wants a nice full profile, full lips, right? Now there's a few situations and of course your orthodontist will measure to see what's right, where sometimes headgear is necessary, but I would say it's very few and far between. And today we're going to be talking about class 2 and class 3 elastics with aligners and what to do if you're not using Invisalign. Obviously, if you are using Invisalign, it's significantly easier. Here's an example of what their precision cuts look like. You can see here. Can you see it on the canine? I'm going to go ahead and hook that on for you. Now, in terms of what elastics to use, you're going to really have to try them in your patient and see. There's no wrong or right answer to this, and it really depends on the morphology of the teeth and the bite So let me show you what this looks like. See, this would be for a class 2 elastics, just hooks right on there. And then down on the bottom, it's going to go ahead and hook to the lower molar. You can use either the first or the second molar. You could either use a button or you can use precision cut to precision cut. So many, many options. It really depends on your personal preference. So we're going to go ahead and show you a diagram shortly about that. If you're going to go from button to button, you can do that too, actually. You can probably use heavier elastics. You might be able to use 3/16 heavy or even possibly 1/8 heavy. If you're going from precision cut to precision cut, it's going to be a little bit different. In that case, let me do that for you. I'm going to set one up for you. You're going to have to use a lighter elastic. You know, in that case, it's going to be a little more challenging because you are going to have to make sure that they're not getting displaced. So let me show you kind of what that looks like. And this is, I'm using a combination of ClearCorrect and Invisalign. But so that's going from slot to slot. Okay. So that means the patient is going to go ahead and assemble this outside the mouth and then put it in their mouth all at one time, as opposed to going from button to button where you're going to put the aligners in first. The buttons will already be on the teeth and then hook the elastics on. What's a class 2 elastic? You can see how the orientation goes. In general, it's an elastic that normally hooks from the upper canine to the lower molar to correct an overjet. The actual size of the elastics is going to really vary. I'm talking about the diameter is going to vary on the amount of overjet or the size of the teeth. So you really should stock several sizes. I would recommend stocking 1/8, 3/16, 1/4. Those are some good ones to stock. Then there's also strengths. Normal class 2 elastics, I'm going to use 6 ounce, but it also depends on what wire I'm on, and we can go into that more later. So do message me, visit StraightSmileSolutions.com if you would like some more suggestions. But this, normally I'll run my elastics on a heavier wire. I'm not going to run it on an eye-tie wire. It's going to be a stainless steel wire. I know that's really different than a lot of other IDB systems that are out there. And I'll run 3/16 heavy. But again, you got to stock lots of sizes. It's not a one size fits all approach for elastics. There's some thought that needs to go into it. Do not run it on a light wire. All sorts of crazy things are going to happen. And that's basically all about class 2 elastics. Take them on, take them off. Every time you eat, they absolutely have to be on 22 hours a day. No ifs, ands, or buts. If the patient only wearing them 12 hours, 16 hours a day, they're not going to work. There's just basically a seesaw effect, and there's going to be significantly more discomfort. So if you do not establish this with the patient and the parent, at the beginning, they're not going to see success. You should, I'm going to say confidently, you will see a change if you're seeing them on 6-week intervals and they're wearing elastics. It will be evident. Okay. It should be quite evident, as a matter of fact. So if you're not seeing the change, you need to be confident in saying you're not wearing them enough. They may be wearing them 16 hours a day, but you need to troubleshoot. That means they need to be changing the elastics at least 4 times a day. Every few hours, they should be changing it. Usually I say 4 times a day: breakfast, lunch, dinner, snack, bedtime. That's 5, something like that. It's okay to change it more. You should be dispensing at least 2 bags of elastics every time that they come to the 6-week interval check. So, and remember, as you're correcting the bite, the wires are going to get pokey. You got to trim it, right? And you still got to check the patient. Hi, it's Dr. Amanda with StraightSmile Solutions. We're here today to talk a little bit about biotrainers, myofunctional appliances, and phase 1 appliances, and how to incorporate them into your practice, how to incorporate them into your phase 1 treatment, how to incorporate them into your phase 2 or comprehensive treatment. And I'm very, very honored that Great Lakes Dental Laboratory has picked me to do a series of videos, educational videos on their biotrainers to help train orthodontists, general dentists, and pediatric dentists for indications of use. And I'm going to be working my way through their series of appliances and telling you more. I have seen a lot of great outcomes with these appliances. This is, I believe, a European-based company, and it's being distributed by Great Lakes in the US. If you have any questions, feel free to contact me, and I'll be glad to talk to you more about phase 1. I have a great monograph or phase 1 quiz that I kind of created, which will help you screen patients and to see if they need phase 1. So I'm glad to send it to you. It's called My Phase 1 Smile. Feel free to email me at info@straightsmilesolutions.com, or visit my website at StraightSmileSolutions.com, and I'll be glad to just give you a copy. I'll just give it to you. It's free. So I'm just glad to be helping people, and that's my ultimate goal. So today we're going to be talking a little bit more about one of the series of appliances, one of the first appliances in their series. It's called U Start. Letter U, Start. Indications for use are age 4 to 6. Okay, so we're thinking either primary dentition, full primary dentition, or very, very early mixed dentition. I would probably discontinue this appliance once the 6-year-old molars came in. So we're thinking like age 4 to 6, maybe 4 to 5. Once the 6-year-old molars come in or the first few front teeth start to come in, it's time to move on to the next in the series of appliances. I'm going to be giving you all kinds of gems and tidbits about phase 1 treatment and how to use these appliances, how to bill for insurance. There's just so much information I can tell you, and it's something that we work with our clients with all the time. So thank you so much to Great Lakes for giving me samples of all the appliances. I'm just going to kind of verbally tell you what I see and feel, and you can see them. So this is the U Concept appliance, the U Start. Again, it's for age 4 to 6. Okay. This is just me saying I would probably discontinue and move on to the next series once the 6-year-old molars come in. These are not custom. Okay. So that means that you can just order them. You can stock them. The prices are very reasonable. You may or may not get a discount or volume discount if you choose to stock them. Is this all you need for phase 1? No, not necessarily. So phase 1 is interceptive treatment. You're getting the kid from A to Z. For me, you don't discontinue phase 1 until 6-year-old molars are fully in and front teeth, top and bottom, are aligned, and as well, and the arches are formed. So, it might be a part of the phase 1 process. Maybe this is all they need, but it's probably pretty unlikely. So some of the features that I recognize in here is basically you've got it's real soft, if you can see how I can just touch it. So I think it's going to be very comfortable. It does come in 3 colors, clear, which is nice because you can see the teeth easily through it, as well as pink and blue. So you can choose what colors you want. It has some eruptive guidance features on the inside, like little imprints so as the teeth start to come up, they're going to bounce off the wall and come a little bit straighter. They also have a firm version, which is a little bit more rigid, that only comes in clear. From my experience, those are good if you have a bruxer. Maybe you want to start with the soft. It's going to be much easier for the child to get used to wearing it if you start with the soft. And if you start getting bite throws, then that's something you can move on to. What else? So I see other features in here that are good. Basically, it's going to work for any patient that has up to a 6 millimeter overjet, as well as a slight class 3 patient. You have to move on to a class 3 appliance if you do have a class 3 patient, but this is a good way to start if they're in early mixed dentition or in primary dentition and you start to see some anterior crossbite. You're probably going to get a little bit of arch expansion, but I don't think you're going to get too much with this. I mean, it is pretty soft. Maybe if you need more arch expansion, you'll want to move on to the more rigid one, or you'll want to go into a Schwartz, or some type of expander, and feel free to connect with me on that. I have tons of YouTube videos on that. Looks like we also have, a little place, I call it a pillow, for the tongue to rest so that the tongue doesn't go down. It remembers to swallow up at the roof of the mouth. So just some tips on delivering this appliance. Initially, a good way, you don't just give it to the patient and say go, okay? So it's going to take some time, especially if the patient is a mouth breather. It's going to take them time to get used to wearing this. And we want to take baby steps. So I usually tell patients, hey, first night, why don't you try to wear it during one cartoon or, one video game or something like that, or while we read a book to bed. And then the next week you can move up to a movie, or while you do your homework. And eventually we're going to try to wear it all night long. Now, some patients might take a few weeks to keep it in all night long. Some patients might take a few months to keep it in all night long. Over time, the mouth is going to grow the musculature to be able to retain the appliance. And the nasal breathing is going to help the patient significantly. So, remember, if the patient has a cold or something, this is not a good time to start this appliance. We want to have patent nasal breathing. So if you need to address that with some allergy spray or something like that first with the child's pediatrician, you definitely want to do it. Also, let's just get into this. You need to be screening your patients well. You can't just give this to a patient because a patient that maybe has swollen tonsils or nasal or oropharyngeal airway blockage, this is not a good indication for the patient. Although this might help the patient, you want to make sure you're working with the child's pediatrician if you are screening melon potty, tonsil, stuff like that. And, you know, refer out as needed and collaborate with the pediatrician or the ENT. And I'm glad to give you some guidance around that as well. So again, this is the U-Start appliance for age 4 through 6, primary dentition or early mixed dentition. It does come in 3 colors, pink, blue, and clear in the soft. And if you move up to the rigid, it only comes in clear. You can order these from Great Lakes. Glad to tell you more. You can go ahead and visit my website at StraightSmileSolutions.com. Keep those questions coming, and I would love to see your cases if you start using them. The number one exciting thing today is that the MA device, the MA feature component of Invisalign, has been FDA approved in the US. This is actually very exciting. You've probably seen some of my videos before. I'm not a huge fan of the design. I think there's a better way to do mandibular advancement. You can watch those. You can watch my criticism on it. But I'm excited that it did get FDA approved. I'm excited that doctors here will have an opportunity to use it. I've had some experience with it, not directly, but indirectly with clients, StraightSmile Solutions clients who have opted to put this into their treatment plans. These are doctors in Canada, Asia that I've worked with that have been using this for some time. It gets kind of mixed reviews from my clients, and we can go over that directly if you have questions. But, you know, it's available. It's there. I believe, and this is my understanding here in the US, and of course, Align Technology never returns any of my questions or inquiries. So I'm just going off what I heard, hearsay, and if they're more than welcome to reach out to me and answer my questions. I believe it's only available in the phase 1 feature, the phase 1 treatment that you can get. I believe it's not a feature in comprehensive treatment at this moment or in phase 2. So that's pretty much all I know. Any questions, please visit StraightSmileSolutions.com. But again, anything that involves growing mandibles when it needs to be grown, of course, you have to know a lot about skeletal growth. You need to know a lot about so much you need to know. And I get very nervous that this power is now available. And I say power because used incorrectly, you can damage a child. That this power is now available for every single dentist out there in the US who's just certified in Invisalign. I don't think you have to take an additional course for it. I think it's just a button you push, and it makes me very uncomfortable, but I'm just saying that. So. Hi, it's Dr. Amanda again with StraightSmile Solutions. This is the next video in the series of my phase 1 smile, in which we're going to be talking about a variety of different appliances that can help during phase 1 treatment or functional appliance treatment, early eruptive guidance treatment, stuff like that. So we've been talking about the U-Concept family of appliances. Again, if you watch my other videos, I want to thank Great Lakes Laboratory for sending me samples of all their U-Concept appliances. I'm going to be working my way slowly through each appliance. And in each video, I'll be showcasing a new appliance and then giving you some tips about phase 1 treatment. So no matter if you're an orthodontist and this is something new for you, this kind of early interceptive treatment, myofunctional treatment, or if you're a pediatric dentist or general dentist and you're just getting into this space, maybe you want to be more airway friendly. Hopefully these videos will give you some tips. Each one will be a little bit different. So today we're going to talk about the next appliance in the series. This one is called U-Trainer, okay? And this is the U-Trainer. There's 2 U-Trainers, okay? This is hard to open. Goodness. Okay. The U-Trainers, there's one for age 6 to 8, and then there's one for, I believe it's 8 and above, or 8 to 14 or something like that. So I'm going to call this U-Trainer Junior and U-Trainer Senior. So this is for the U-Trainer for kids that are in the early mixed dentition. So earlier we talked a little bit about U-Start. Before that, there's U-Kitty. So U-Start, this is pretty similar to U-Start, but it's definitely a little bit bigger, and it has higher flange, as you can see, much higher flange. So the benefits of this is that it's going to help with overjet up to 6 millimeters. It looks like it's not focusing as much on tongue position as the U-Start that we had earlier. But definitely it'll be great for eruptive guidance, kind of pre-eruptive guidance therapy as the teeth. There's definitely little parking spaces, if you can see, with the teeth. As the teeth come in, they're going to bounce off these walls, and they're going to basically be guided into place, which is really awesome, right? The other good thing about these appliances is that they are not custom made, which means that they're a much lower price and that you can stock them ahead of time. So this is going to be a part of your phase 1 treatment. So you're going to maybe start with this, get the musculature up and running, get rid of oral habits, help to guide teeth a little bit more into place, have a healthy airway, and then you can always move on as needed into some light phase 1 aligners, you know, Invisalign First has one. You can do a white label for that, or you can go into some phase 1 braces as needed, but you may not need them. A lot of times when you do these, when you expand the arch to the right width, a lot of times teeth just drop where they need to. So you could easily marry this if needed with an expander first and then go into this. Now you're going to get a little bit of arch expansion. It's definitely more rigid in the back than the one we did earlier today, which was the U-Start. Walls are a little bit higher, and you can also get this in pink and blue. This is the soft version, okay? So I believe there might be a more rigid version out there too. I would definitely start with the soft and work your way up if you're getting bite throughs. But again, this is the U trainer, and it is for age 6 to 8, okay? And there's a bigger version for 8 to 14. So again, these ages are kind of a little bit relative. You might want to try it in. I mean, I would definitely use this appliance for somebody that had their 6-year-old molars in, maybe not all the front teeth in yet. Once they have the 8 front teeth in, you'd probably want to move up to the next appliance in the series. Great appliances. I've seen a lot of great outcomes, as well as I think it's just a healthy way of being. The kids are going to be breathing through their nose more at night. They're going to probably feel better. I mean, this is not a promise, but you can't make promises like that, but feel better, behave better potentially. There's a lot of positive things that seem to correlate, and there's still a lot of studies that are coming from using these kind of appliances in kiddos, but I'm really excited to study them more and to see more awesome outcomes. Price point is super low, and there's no actual training at this moment that is required in order to prescribe these appliances. It's not something that's direct to consumer, so you'll need to order it from Great Lakes. They are the distributor for the United States. Beyond that, there's other distributors internationally. So yeah, ping me if you have any other questions about the U-Concept series. You can contact Great Lakes directly to order them, or I'm glad to introduce you. In addition, if you want the copy of that screening form, the My Phase 1 Smile that I developed, I'm super glad to send it to you. It's free. You just have to visit my website, StraightSmileSolutions.com, or email me at info@StraightSmileSolutions.com, and I'll be glad to send it to you. Thanks so much. Hi, it's Dr. Amanda with StraightSmile Solutions. Let's continue today on our series about U-Concept U-Trainer appliances, specifically distributed by Great Lakes, Orthodontic Laboratory. Overall manufacturer is 7Cs. If you've watched the other videos I made on these products, I've made a whole series just based on my experience, not only with these products specifically, but all kinds of other malfunctional devices, biotrainers, eruptive guidance appliances, etc. I have a good, I would say, 4 to 5 years experience, and I've probably seen well over 1,000 cases once you kind of factor in all the different appliances that are out there, all the different systems that are out there. Recently, there was FDA approval of this new U-Concept appliance. It's not that new. It's been around in Europe for quite some time. Just super excited. That's an affordable appliance, and it's something that a lot of my clients are using now, kind of integrated into their overall phase 1 treatment plans. So it's not always the only appliance they use. I think that's the biggest mistake that you can make, thinking this is like a one-stop shop, a cure-all. You just throw an appliance at them and it solves all the problems, and that's not the truth. So it's just going to be part of your overall plan. And very likely it's going to be the first part of the plan. And then you might move on to something later, like braces, aligners, or even another functional appliance or something like that. So let's talk about the Class 2 appliance today. It's called U Class 2. Indications for use, according to their instructions, would be ages 6 through 12 with a 6mm or greater overjet. I'm going to tweak those indications now that I've seen a few cases and I've seen the appliances hands-on. My version of it would be, I don't think a 6-year-old could wear these. They're way, way, way too big. There's no way. So I'd have to be an awful big 6-year-old, or you'd have to really trim it in order for them to wear it. I would definitely start with their U-Trainer first, U-Kitty U-Trainer, work your way up to these. Definitely 8 or 9-year-olds should be able to wear these. You're going to start with the soft for sure. This is the soft. And remember, we looked at the class 3 one earlier. This is setting the bite differerently. So this is going to set the bite at a super class 1 or edge to edge bite. It's going to work very similar to a twin block, a BIONATOR, or anything like that. So an activator, any of those type of appliances. Benefits are going to be improved airway because it's going to stimulate the lower jaw for growing, more oxygenation of the blood, which also can help, you know, with behavior and other things. Again, these are not 100% scientifically proven. These are just anecdotal, but based on stuff that I've seen and other doctors have seen. There's a lot of awesome positive benefits that will happen when you use these appliances, as well as they can help with a little bit of arch expansion, relief from crowding. Basically, they're eruptive guidance appliances, so the teeth are going to come in, if you can see, and they're going to kind of bounce off the walls as the teeth come in. So the best indication for use is to start from these like when the kid is 5, 6 and they lose their first tooth, and you work through the series of appliances, and the teeth are going to bounce off the walls and come in straight, or pretty much straight. And it's going to be straight enough. If you have the right arch width, then things just generally come in straight. It's when you have a constricted arch that teeth are going to come in crooked, and that's where we have to think about doing canine exposures, taking out teeth, stuff like that. So this is why we want to get started early. And again, if you're interested in taking my assessment, it's called My Phase 1 Smile. I developed it. It's a quiz that you can do, or an assessment form starting on very young child, looking at all kinds of things, oral habits, looking at the x-rays, and deciding whether it's time to do phase 1 treatment or not. It's free. I'm happy to give it to you. All you have to do is visit my website at StraightSmileSolutions.com and message me, and I will send it to you, and it's free. So I think a lot of people find it really helpful. So again, let's talk a little bit more about these class 2 devices and how they're different from the regular trainers and the class 3. Definitely they have some super thick, you know, on the top, it's pretty darn thick. That's going to keep the front teeth from flaring forward. Bottom's pretty long too. And definitely there's a higher kind of shield here that's going to keep the tongue from pushing the teeth forward. Some of the other appliances are a little bit better for training the tongue and getting rid of oral habits and stuff like that. I can see the buttons here that are meant to have the tongue expand the arches. That is more of an indication in the firm. You can see in the soft, that's not in there. So definitely if you have crowding or arch constriction issues, I would move your way up to the firm. I can see it's definitely a better appliance, but I think there's almost no way you could start with this appliance. It's just not going to be tolerated. It's not going to be something that the musculature can keep in. It's not going to be comfortable. They're not going to be able to sleep. Make sure that you follow all my other videos where I take you step by step through these appliances, give you tips on wearing them. And remember, you can't always only use these appliances. I've talked to you about that, how you might have to tag team it with an expander, or most likely you're going to have to move into a few finishing aligners or a few just couple braces at the end. And that's something that we can definitely help you with. If you have questions, it's really, really easy. And if you're getting started early, or if you have questions about insurance and billing, I'd be glad to give you a lot of tips on that too for phase 1. So anyways, so much to say. I could probably talk for 3 hours on this, but definitely a big fan of these appliances. Check them out, or buzz me and I'll be glad to. Hey, this is Dr. Amanda with StraightSmile Solutions, and today I'm going to be talking to you a little bit more about deep bites. I'm getting all psyched up for our webinar. I'm going to be co-producing this with Ohlendorf Laboratory. Right now, if you want to register for it, you can go to StraightSmileSolutions.com/media. It's in our webinars section, and you can go ahead and sign up for it. But everyone is excited to learn more about phase 1, and today we're going to be doing some content about deep bite correction. So real quick, this is my go-to solution for any patient with a deep bite, but let alone a growing patient with a deep bite, especially a phase 1 patient with a deep bite. Here's an example right here of what's going on. So you can see there's a pretty significant deep bite. Of course, you like to verify it. Taking a ceph is nice to verify the numbers as well, looking at it clinically. This is the model here. So what do we do, right? Now, most orthodontic treatment will help to level out the arches, especially if you get on the lower molars. That will go ahead and help correct the deep bite a little bit. But if you want a super fast correction, this is my go-to solution. Also, it has the added benefit of helping you get on the lower teeth sooner if you are doing phase 2. So this is called a fixed bite plate. And again, this was a sample that was donated to me by Ohlendorf Laboratory. There are a lot of laboratories that do make this, but I will be co-producing our webinar with Ohlendorf, so I just want to give them some props. But you can have this made in a variety of different colors and shapes. This is a clear acrylic that's made there, but I always recommend that you let the patient have fun with it. Pick a color, pick glitter, let them own their appliance. They're going to be way more excited about it, okay? So basically the steps are that you're going to go ahead and throw some spacers in the back molars initially, okay? So let's say this is your patient. You're going to go ahead, throw some spacers in. Then I would take the scan or impression and send it off to the lab with the instructions, please fabricate anterior bite plate. And there's also fixed and removable versions. This is a fixed with bands, okay? If you're gonna be going on to doing brackets, you should ask for them to solder buccal tubes on there. If this is just phase one and you're not gonna be doing any braces, you're just doing bite correction, you don't need to have the tube soldered on because that's usually a little extra money. There's also a removable version. It looks like a retainer. Of course, that's gonna be compliance-based, so pick your patient wisely. So that's pretty much it. You send in the scan or impression. I usually recommend throwing the spacers in first and taking them out before you do that. That way they can fit the bands better. If you have bands in stock, you can fit your bands first, do a pickup impression, but this is a lot easier. Then you don't have to worry about stocking bands. It comes back to you like this. You go ahead and put your band glue in, thin layer. My favorite band glue is made by 3M Unitech. It's called Band Lock, B-A-N-D-L-O-K. Comes in colors, so when you go ahead and load it and allow it to light cure, it's going to change to clear from, I think it's purplish, purple blue. But if the fit is not very tight, then I recommend using like a Fuji-based modified glass ionomer because it's a little bit thicker. But I wouldn't use that unless you really need to because you're gonna have a hard time getting it off, okay? So yeah, you just like literally try it in first, make sure it fits. If it fits good, take it off. Having a band remover is helpful to take it off, but you don't have to have that. You know, you can just do it with cotton rolls and fingers too, depending on the fit, right? And then yeah, cement it. So cement it right on like this, okay? And light cure it, and that's pretty much it. Let it cook. This should actually stay in, I would say, a good minimum 4 months. I would like to see that in, if not longer. So let me show you what it looks like, the difference of what it looks like. Right? Super deep, right? You only see, I'd say it's about 60 to 70% deep bite. We see a little bit of the lower incisors, but not all. This is not a good deep bite. Now, those of you don't know that much about overbites, this will get worse over time. It will not get better. You need to have confidence in telling your patients that, okay, as they grow. So it is a progressive disease, and over time, the lower teeth will start to touch the roof of the patient's mouth and cause fremitus and periodontal destruction. So you must correct this. And the younger the patient is, the better it corrects, okay? So now let's see what it looks like once we put the appliance in so you can see the difference. Holy cow, right? So if you had lower brackets on, whoo, you know, we don't even have to like put those kind of junk bite bumps on the back. This will naturally allow the curve of speed to level out, whether you have braces or not. If you have braces on, it happens even faster because you can run some box elastics. I usually run my box elastics. So I'll run my box elastics not in the initial wire, but I'll run them, if you are doing braces, maybe once you get up to an 18-9 tie, and I'll run them from molar, molar, canine, canine. So it's a box, okay? So 3, 6, 6, 3. If you're talking international numbers, that's on this side. That would be 2, 3, 2, 6, 3, 6, 3, 3, okay? I usually would use for box elastics, I'm gonna use quarter medium in an 18-9 tie, okay? And I'm gonna stay in that appliance and in the box elastics until the bite fully touches on the sides. And you can see right now, the bite is open, right? So until all the teeth are occluding, you can check with articulating paper, the appliance stays in, okay, on both sides. And if patients want to speed it up, they can wear their box elastics. Again, if this is phase one, you don't have, you know, brackets on all the teeth, no need, just let it settle on its own, right? And you can also build an anterior bite plate into removable appliances like Schwartz's, like sagittals, and all kinds of other things that you want to do it. So you can really kind of bling them out. It's really cool, kill two birds with one stone. Really awesome in a phase one case, and we're going to be teaching you more about that in our seminar on November 5th. So we hope to see you there. And you can even modify the bite plate to make it inclined, which kind of makes it act more like a class 2 appliance. So wow, I know that was a lot of information. So I do recommend that you connect with us to learn more at StraightSmileSolutions.com, and we will tell you more about how to use a bite plate. All right, thank you so much. We hope to see you soon. Don't forget to visit our website. You can schedule an appointment for a complimentary consultation to learn more about ortho in your practice, whether you want to do phase 1, phase 2, aligners, braces, straight wire. We have a little bit for everybody. And yeah, don't forget to check out Ohlendorf Dental Laboratory as well. All right, thanks so much. Have a great day. Hi, this is Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today we're going to talk about this fun phase 1 case which has congenitally missing lateral incisors. That means 7 and 10, or the upper 2s, are missing in the permanent teeth. So as a result, you see this splaying of the front teeth. Sometimes you might want to double check, because sometimes you also, when you see this, you might have a mesiodens or a supernumerary tooth. So whenever I see this, usually I know that they're missing permanent teeth. I also know there might be something funky going on, so always take a pano and check. But the other thing that I see is a really nice maxillary labial frenum. So this means this patient will need a frenectomy when it's done. Looks like she also might have a habit. There is a crib in there. So this is a lot, there's a lot going on right here in this phase 1 mousetrap. Personally, this is not the way that I would close this diastema. I don't think this is going to be incredibly predictable. It's just going to be tipping and retracting. The better way to do this would be to either use phase 1 braces or aligners along with the fixed habit appliance. But what they're doing here will improve, but it probably won't perfect. They won't get root correction. So it wouldn't be my preference, but maybe price was an issue. I mean, nowadays with easy white label aligners, it just doesn't make sense to me to use such a mousetrap. But pretty cool. Like, they're clearly retracting with the labial bow. They're using these finger springs here to help to tip 8 and 9 together. And they've got a crib in there to help with whatever habit. And remember, with frenectomies, you don't do them until the space is fully closed and the roots are corrected. So I would not rush to do that, because you could get scar tissue in there that would prevent the correction. So hopefully this was interesting to you. I love this type of cases. Really, really fun. Good thing they're correcting the habit. I would also do a full SDB evaluation and be checking the patient out for everything else. And then things to think about: what's the plan with 7 and 10 later, temporarily later. For me, anytime I have missing teeth, I'm going to prefer something like Invisalign or some type of aligners, because it's really easy to fill the Pontics. Pontics in braces are a big hassle. So this is a no-brainer for me. I'd be doing phase 1 aligners on this patient, would be my preference. Or phase 1 braces without Pontics would work too. All you'd have to do is bond maybe A and J. Most likely you could do 3 and 14, but some type of back tooth, as well as these 2 teeth, level and align. Get into a heavier wire with some cinch back, some buccal tubes, and close that diastema right up with actual translation of the teeth. And then most likely, once it's closed, do a frenectomy, do a bonded retainer behind the upper ones, and wait for the rest of the teeth to come in. All right, thanks so much. And as always, please do subscribe to our YouTube channel, slap that button, and we would love for you to check out our book. It's on Amazon. Check out our website at StraightSmileSolutions.com and keep those questions coming. Thank you. Dr. Amanda from StraightSmile Solutions, and today we're going to be talking a little bit more about expansion, specifically expansion in phase 1 patients, and when to use an expander. And unfortunately, there's no easy way to wrap this up in a tidy box with a bow. It really just comes with experience. But I'll go through a few scenarios and give you a few tips of kind of how I advise my clients when to expand and how I teach them about expansion. And over time, as they start to see more and more patients, they start to understand. So if you have any questions or if you need help with a case, feel free to visit StraightSmileSolutions.com. There is a link under the services page to sign up.
so that we can help you immediately with your cases. So basically, in a nutshell, let's talk a lot about what is an expander and what is expansion. So you can get expansion in a variety of different ways. If you're looking for dramatic expansion or expansion more than 2 to 3 millimeters, I do recommend an actual expander. This is a fixed expander right here. This is our Schwartz or removable expander. You can see that there's like a jack screw in the midline area. So a fixed one means it's glued in. In order to make this one, you're going to want to put spacers in first if you need them. Take a scan or an impression, send it to the lab. They'll fit the bands and construct this. You'll put the spacers back in a few days before delivery, pull them out at delivery, and deliver it. You're going to bond this just like you would a space maintainer with some, I like to use like, there is band cement, but usually I'll use like a key tack type of thing, modified glass ionomer. That works good. Of course, my first choice for expanders is always the removables like these right here. Just speak for hygiene, for our patient experience. If you'd start doing a lot of bandage, you're going to have a lot of emergencies and a lot of drama. So always good to start with the removable, explain compliance to the patient and parent, and explain the upgrade fee process if they need to upgrade to banded. I usually recommend charging an additional maybe 200 to 300 per arch if they are non-compliant and they need banded. Of course, if the parents are adamant that they want banded and not removable, that's fine. You can start there. Of course, you're not going to charge that upgrade fee, but you let the parents know there's going to be a lot of food restrictions, and if there's multiple breakage or emergency appointments, there may be additional fees for that. Usually, like I said, this is just a way better experience for everyone. There's almost no 8, 9, 10-year-olds, 7, 8, 9, 10-year-olds that I can't get to be compliant, assuming that I get a pretty good vibe initially when I get to know the parents and the kids, see how the dynamics are going. I'm looking at lots of things on the kids. Is the kid brushing her hair, brushing their teeth, trimming their nails? How's the skin? How are they dressing? Are they generally a compliant child? And how is the relationship between the parent and patient? Is this something, if I give them something simple to do, which is just putting this in your mouth and wearing it during the day, taking it out during lunchtime, putting it in a case and brushing it, are they going to be able to do this? And if I see a patient that comes in who's disheveled, unwashed, unbathed, can't handle basic hygiene, then no. Matter of fact, I might not partner with them at all, or I might wait till they get a little bit older. So just things to think about. So anyways, I digress. So you can get some expansion in these type of pediatric, what do we call them? Biotrainers. So you can get maybe 2 to 3 millimeters max. But if you're really looking for dramatic expansion, you really got to go with the expanders. For me, I like to go slow and low unless there's some reason, some urgency. And it really depends on the frequency of turns, really will depend on the age of the patient, the skeletal maturity of the patient, what our objectives are. Usually maybe 2 or 3 turns. On a removable per week, maybe a little bit more on a fixed. Total turns will depend on how the patient responds. You have to keep a close eye on it. Of course, don't want to overturn. You want to make sure the patient's coming back regularly every 2 to 3 weeks or 3 to 4 weeks in your office to be checked. You're checking a bunch of stuff. We can talk about what that looks like. So, I had one patient that they basically ghosted. They disappeared. They hadn't expanded and they were just cranking it like crazy. Of course, there's a limit eventually to how much it cranks, but they totally blew the bite, we lost control of them. We tried to get a hold of them. We were sending them letters and certified letters, but you really don't want to be partnering with parents that you don't have a good connection with, because you are basically breaking the patient's jaw. It's not fused, so it's not broken, but you're, distracting it. And things can happen if it's done incorrectly. So you don't just want to be doing this, out of control. Okay, so more things. You can bling out these expanders in a variety of different ways to control habits, tongue position, tongue thrusts. You can also straighten teeth by putting all kinds of little screws and pistons in them. There's so much cool stuff you can do. The cool thing is that if you expand patients when they're young, with these kind of $100 to $200 expanders, and just let them be, the teeth actually come up usually quite ideally to begin with. They don't come up crooked because you made space for them, assuming you're doing this before too many teeth are in, when the patient is 6, 7, 8.
9 maybe. Not when the patient's 11. That's not going to do much. You're going to have to do braces too. A lot of times if you do this really young, you don't even need braces. Or if you do, the need is like need, not need. It's a want. It's not a need. It's just aesthetic. So that's pretty sweet. And you can take a case from a 2-year braces case with extractions down to a 3-month clear aligner case, just because you made space at the beginning, and it ends up being way cheaper. Again, more cool ways. I mean, you can make these things really fun. If you're going to put all kinds of bling and glitters and decals in them, of course, it's going to cost a little bit more. This is an expander here as well, but this is also an expander that it works similar to the Invisalign MA appliance. As a matter of fact, this is the original Invisalign MA appliance. This is a twin block. So it's going to advance the mandible, help grow the mandible, as well as correct the jaw. And the bite. So that's pretty cool. I mean, what type of 7, 8, 9-year-old girl would not want to wear this to school? They trust me. They all want to wear this to school. That's really cool. So, again, more different modifications. This one you can use, and this is an older kid, so you're using it at the same time as braces. This is a fixed appliance, but it has acrylic on the posterior teeth. This is like caries waiting to happen. You have to have a really great patient. You got to have a really close eye on this, but this would be really great for a patient who maybe had an open bite or a habit, an open bite, because this is going to help to close an open bite. All that acrylic on the posterior teeth intrudes the posterior teeth, closes down the bite. So, and you can make the opposite for a deep bite. So many cool things you can do for $200. So anyways, if you want to learn more about expansion, please visit StraightSmileSolutions.com. All dentists in the whole world can schedule a complimentary consultation with us. Just go to contact us and schedule it. You can also email us at info@StraightSmileSolutions.com. We hope to talk to you soon, and we're excited to answer more questions about expansion. All right, thanks so much. Amanda here with StraightSmile Solutions, and today we're going to be talking about posterior crossbites. I know we talked about anterior crossbites. Posterior just means back of the mouth. So you can see in the back where the molars are, that's how the top teeth go in relative to the bottom teeth. That's what we call a posterior crossbite. The top teeth are actually supposed to be out, about half a tooth wider than the lower teeth. So this is about a half a tooth narrower. So it's quite narrow. It's important that you catch this when it first starts to happen, even if it's happening when they're really little, 2, 3, 4, 5, because these are things that should be corrected. You need to find out why that's happening. Why is it happening? Most likely it's related to diet. It could be related to thumb sucking. It could be related to bottles, pacifiers, many different things, but you do need to correct it. I would say as soon as you start to see it. I would not wait till the child is 10, 11, 12, because it makes it much more difficult to correct and makes it much more uncomfortable, and sometimes makes it less stable to correct. And there can be lots of health benefits to getting the upper arch to the proper width, in terms of airway, tongue position, speech, and other things. So any questions? This is something I feel very passionate about. So we're getting out of the whole aligner thing, and we're going to move into the next bucket, which is phase 1 and functional appliances. So if you're a pediatric dentist, you're probably super jazzed about this. If you're a general dentist, you may not be that jazzed. But kiddos are kiddos, and I'm going to get you so excited about seeing kiddos because they're actually the most fun patients possible. And doing phase 1 and functional appliances is a blast. It's so fun. And you know what? If you don't like kids, fine, who cares? Get a team member who does, because I guarantee you some team member in your office is one of those bubbly, fun people. Maybe they have kids, they love working with kids, and they would just own this. And you could give them little bonuses for, here and there, whatever you need to do to get them super excited. But the vast majority of phase 1 and functionals, you as a dentist barely need to touch the patient. It can be totally run by your team member. Of course, within your own Dental Practice Act, you're doing the diagnosis, you're doing the delivery, you're doing the treatment plan, but the check-ins can be done by your team members because there's really nothing that has to really be manipulated as long as you're using removables, which is my favorite. So this is actually my daughter. This is one of my favorite slides. But you can see here, we started in 3rd grade. We did some expansion. She had about 4 millimeters overjet, about 90% overbite. We expanded. We also have an impacted canine here. We consolidated the front spaces, and now we're actually in the fun part, which is the canine exposure. But at least we got the hard stuff out of the way. We fixed the bite. We got everything lined up in the phase 1 with removable appliances, and now we are moving on to the more difficult part. But this could be something where in your office, you could do the fun, easy part, getting everything ready, the phase 1, and then you can punt it to ortho as needed for the phase 2 if there's something that you weren't expecting. It's only a small commitment, phase 1. So phase 1 is a small commitment, normally around 6 to 15 months, depends on when you're starting, where you're just fixing, it's interceptive, right? You're fixing initial problems so that everything, if you line it all up and you get the space, everything is gonna just come in hopefully peachy, at the end. Doesn't always happen that way. Weird things can happen, but for the most part it does. And a lot of phase 1s, when you start them, sometimes you don't even need phase 2. So that's just a blessing. And if that happens, the parents are gonna think you're the best thing ever. They're gonna be singing your praises. Can't promise, never promise. All you can do is promise that it will help to make the phase 2 less complicated. You're taking the hard stuff, doing it now, early when the patient is compliant and likes to wear things. No one wants to work on 13 to 14-year-olds. It's not fun. They're grumpy. They don't want to be there. But the 8 and 9-year-olds want to be there, and they would love to wear whatever you give them. They think it's the coolest thing ever. It's just so cool. I can tell you, when I was 8, I made retainers out of paper clips and now in layers, and I wore them to school, and I did such a good job making them that the teacher actually thought they were a retainer. And they told my mom, I think in a conference, oh, she's wearing her retainer. My mom's like, what? So who would have known I would be an orthodontist? But I did think they were super duper duper cool. So, but yeah, phase 1 price point, I'd say people are charging between $2,500 and $39.99. It really depends on, if you're in network, insurance, all that kind of stuff. Depends on what you're doing. Some people will start phase 1 even younger, and I call that kind of like a super phase 1 treatment, or you might do a pre-phase 1, which is maybe just like a habit intervention or an airway appliance. There's a lot of those that are really great for 3s, 4s, and 5s. If you're starting phase 1, though, you need to keep with the patient until you fix the bite. So I would say at least until the bite is corrected, and also the front teeth are out of harm's way. So that might mean consolidating, doing some braces on the top teeth, doing some express aligners on the top teeth, doing Invisalign first on the top teeth. So you need to stick with that patient. You can't just wear a little rubber appliance and say, okay, I'm done with phase 1, because you didn't address all the patient's needs, right? And then in between phase 1 and phase 2, you're gonna have kind of a latency period, might be a few months, might be a few years, where you're just gonna keep an eye on them every 6 months until they're ready for phase 2. The great news is, if you do phase 1, you can tell the parents that the likelihood of needing really complex stuff and invasive stuff in phase 2 goes down significantly. So it decreases the likelihood of needing jaw surgery, having impacted teeth, needing 4-by extractions or anything like that. And we really harness the growth of the patient in order to get a better outcome. So for example, if you take out upper buys on an overjet patient, all you're doing is just camouflaging, right? And you're making a suboptimal patient profile. The profile isn't looking as good. Better to grow that lower jaw if you have a deficient mandible than to pull out upper teeth in phase 2, right? But the biggest mistake often that general dentists make is they don't realize that they need to harness the growth. So they have to really know where the patient is in their growth. And of course, orthodontists are really in tune with this. Pediatric dentists, pediatricians, we know when the growth spurt is happening. You're probably not going to know, and you can't always tell by looking at a patient. You need to ask the right questions, and again, that's where it comes back to the hand wrist X-ray is really helpful. But ultimately, you need to be asking those puberty questions. Can be a little bit sensitive, so you can always task, one of your female team members to ask the questions on the girls if that's something that you need to do. But you need to know, because again, we talked about understanding ortho so that you can qualify the referral if you're not going to be taking it. So if you don't understand, if you're not explaining to the parent that, yes, we need to start phase 1, we need to send you to ortho because little Jenny here is 8 and you're telling me she's already starting to go through puberty. Well, there's 8-year-olds that are done growing, done. You go to a 3rd grade class and the teachers will tell you they're done. They're fully grown 8-year-olds, especially girls. So girls are done growing earlier than 2 generations, for sure. Somewhere the average age, I think, is around 9, 10 now to be done growing. It's much, much younger. Boys as well, a little bit earlier, a little less so. So, you have to time the growth with the maturity, and they may only have 8 permanent teeth in, but yet they're done growing. So what do we do? So that's why the phase 1, phase 2, that's why it's so important. So definitely want to talk about it. This is just a great example of one of my cases of how you can do phase 1 aligners. And I was doing phase 1 aligners before they were even a thing. So Invisalign First obviously came out. It's pretty expensive. If you do Invisalign First, you also have to do Invisalign Second. So that's like a $3,000 lab fee almost. Wow. But guess what? You can do it with white labels. You can do it with ClearCorrect. They're totally fine. They don't market it, but you can. You just pay for the flex price. Or in this case, I paid for the unlimited price because I figured that I have 5 years, right, to go ahead and do it. So I can do as many revisions as I want with unlimited, but really great for space consolidation. So much easier than doing braces on the front 4 teeth. Often you don't even need attachments if you take it slow and easy like I did here. No attachments, just wear it 22 hours a day. 9-year-olds, 10-year-olds, they would love to wear this. They're gonna think it's so cool. So definitely. So here's some of the different types of appliances, and I've got some of them here. I might show us for demos. So we've got, of course, whoop, dropping stuff. We've got expanders, right, with a little key. There's fixed ones and there's removable ones. Here's a nice little removable one. So this is called a Schwartz. So there's a little key that they're going to crank at home in order to widen the jaw. Obviously, this is a lower one. So on the upper, you're actually splitting the palate if the patient is still growing. If the patient's not growing, all you're doing is tipping teeth. On the lower, you're just tipping teeth, right? But it's a great way to develop out the arches so that if you, like I said, if you grow it, they will come. So if you develop the arches and put the arches where they should have been, you know, if they had developed ideally, then the teeth often just come in perfectly to begin with. So it happens. So that's the exciting part. So you've got myofunctional trainers, you've got space maintenance appliances, you've got different growth modification devices, like say a twin block that's here. What else? Habit appliances, headgear. There's like a little fixed habit appliance. There's also removable ones. Don't have to do anything sharp or pokey. There's a lot of stuff out there. So many different things you can do. We talked a little bit about hand wrist x-rays. Again, I developed my own index for this to make it easy. If you have a ceph plate, you can take a hand wrist x-ray. Great way, especially if you don't want to ask the questions or if you have like a parent that's just not very communicative. You can just take the x-ray, get your answer. You know if they're going through puberty, if they're about to, how much growth you have left. I also have another handout called My Phase 1 Smile Index. Glad to send it to you. Normally there's a fee for that, or it's only for my clients, but anyone that was on this garrison, as long as you contact me by the end of the week, I will send it to you. I usually want to talk to you first just to make sure you're going to use it in the right way, because I had some people that wanted to sell it once, so we might chit chat about it, but this is a great screening form just to make sure that you understand the why behind phase 1. You're checking all the different little boxes to know if this is a potential phase 1 patient. So, and this is just developed based on my experience with patients. It's also really important to have some type of sleep or breathing questionnaire. There's adult ones, there's kids ones, there's a bunch on the internet that you can get, that you can repurpose just with ideas, but you know, just questions about feeding, pacifier, oral habits, skeletal maturity, if they've ever had their tonsils out, if they breathe through their nose. I do recommend that you also take the time, especially if you're seeing like patients with open bites or narrow upper jaws, if you're seeing, you know, something that looks kind of off with the bite, to have the parents fill out a questionnaire like this. But more importantly, I would say have them come in, you know, at like 10, 11 o'clock at night, get their phone and tape the patient. You know, it doesn't even have to be, it'd be nice if it's a video, because it's nice to see them kind of their mouths open, stuff like that. But 5-10 minutes, a couple different blurbs, bring it into you, look at it, and you're going to see a lot of really interesting information about the patient's sleep, which is directly related to their orthodontic condition. So it's really quite intertwined. And parents often have no idea that, hey, you know, if I fix their bite, they're going to be sleeping better. Well, if they're going to be sleeping better, they're going to be acting better. They're going to be, I mean, this is, I know you're extrapolating it way out, and I know it's really kind of fashionable right now. There's a lot of different courses about this, but it really is true. We can't make promises like, oh, we're going to cure this, you know, this kid from this condition, but you can say that there is a correlation, and that often having a patent airway, a really good airway when the patient's sleeping, has a lot of favorable health considerations. And that's pretty much what you can say, you know, and that includes, of course, Mal and potty, checking all that, checking adenoids, checking tonsils, and just having an idea about the airway. So talk a little bit more. We've talked about expanders, fixed, removable, bonded, so many different options out there. The cool thing about expanders is that you can bling them out, especially the ones with acrylic, the removable ones. The patient can customize them, put decals on them, really own it. and they just get so excited. I'm much more of a fan of removable expanders. I have no problem getting patients to be compliant. It's all in how you explain the why behind it. Usually you're going to have way more emergencies with a fix than you were with a removable. And I mean, they're not like huge emergencies, but it's annoying, you know, in terms of disruptive for a practice. So removables, I mean, it's fully on the patient to wear them. So, but for the vast majority, they wear them great as long as you explain, and you don't have to worry about all the food getting stuck up there and the infections and stuff like that can happen.
All right, let's get started. So you've probably heard me talk about rapid palatal expanders before. I'm a huge fan of them. They're great. This is a banded one, so that means that they can fit the bands for you. But it's always better, I think, if you drop some spacers in first. It just helps them be able to fit the bands better. And then do your scan or impression like about a week in advance. You can also fit your own bands and do a pickup impression, but that's a little bit tricky sometimes because they can lift when you pour them up, so I wouldn't recommend that. Let the lab go ahead and fit your bands. Just remember, if you're doing these kind of expanders, I recommend knowing the skeletal age of your patient before you do it. If you don't know how to do that, we've got tons of videos on that, or you can go ahead and connect with me. It's really important that you're not doing these on skeletally mature patients, or if you are, you need to know what you're doing because there's huge risks. So I don't recommend that unless you have experience doing that. So side effects are significantly bigger. All right, so back to the Hyrax RPE, usually used on growing kids or young teens to expand skeletal crossbites, develop arches, etc. In short, the amount of turns is really going to depend on the skeletal age of the patient, what you're trying to accomplish, so I can't give you a one-size-fits-all approach. But this is generally done faster than some of the other appliances, the banded ones. So you're going to see a pretty rapid result, but at the end it needs to be retained or stabilized. So ultimately it all takes about the same amount of time. This is a quad helix. So a quad helix is a slower expansion device. You cannot leave this in here for a really long time because all sorts of crazy things will happen to the arch, to the teeth, to the buccal plate. I've seen it. You don't want to do it. So from my experience, I usually leave these in about 3-4 months max, just to develop the arch. I use these in adults to develop the arch for really slow expansion. You do have to activate these. Sometimes they come pre-active, so you need to know the difference. You can't just plop it in if you don't know what you're doing. I will do some videos on activating it later. It's a little bit tricky, but once I have one in my hand, I will do that for you. All right, so the next one that we're going to do here is what I call a bonded Hyrax. It's basically a banded one that we saw up here, okay? But there's acrylic over it. So it's great for open bite patients. That's what I would use this for, or open bite non-compliant patients will be really great. If you want to make it extra funky, you can put a thumb crib or a tongue crib on the front. Kind of mean, but it's really, really effective with open bite patients. So that's one of my favorites. Downsides, kind of hard to eat. Also, there's a risk for decay, so please don't put this in your non-compliant patients that you aren't following up with, but it's a great appliance. Works the same as this one up here, same stipulations and regulations. Next one, I call this a unilateral Schwartz. Maybe I should go to the regular Schwartz first. This is your standard Schwartz, okay? So this is basically a slower version of the RP that we had up here. Slower, less turns. Great because it's removable, customizable, fun colors. You can do it a little bit in a little bit older patient, or you can do it in a really little patient. You don't have to worry about having permanent teeth in, banding to permanent teeth. Very compliant. So I think that's a great appliance. I use them all the time. It can also be customizable. You can add acrylic to the posterior teeth. I don't have that feature right now to help with open bites or vertical issues. You can add a thicker bite plate on the anterior to help with deep bite issues. Fantastic appliance, by far my favorite. This is like kind of a funky version of it. As you can see, this probably is for a patient that has some type of unilateral crossbite issues.
Dr. Amanda from StraightSmile Solutions, and today we're going to be talking a little bit more about expansion, specifically expansion in phase 1 patients and when to use an expander. And unfortunately, there's no like easy way to wrap this up in a tidy box with a bow. It really just comes with experience. But I'll go through a few scenarios and give you a few tips of kind of how I advise my clients when to expand and how I teach them about expansion. And over time, as they start to see more and more patients, they start to understand. So
If you have any questions or if you need help with a case, feel free to visit StraightSmileSolutions.com. There is a link under the services page to sign up so that we can help you immediately with your cases. So basically, in a nutshell, let's talk a lot about what is an expander and what is expansion. So you can get expansion in a variety of different ways. If you're looking for dramatic expansion or expansion more than 2 to 3 millimeters, I do recommend an actual expander. This is a fixed expander right here. This is our Schwartz, a removable expander. You can see that there's like a jack screw in the midline area. So a fixed one means it's glued in. In order to make this one, you're going to want to put spacers in first if you need them. Take a scan or an impression, send it to the lab. They'll fit the bands and construct this. You'll put the spacers back in a few days before delivery, pull them out at delivery, and deliver it. You're going to bond this just like you would a space maintainer with some, I like to use there is band cement, but usually I'll use like a key tack type of thing, modified glass ionomer. That works good. Of course, my first choice for expanders is always the removables like these right here. Just speak for hygiene, for our patient experience. If you'd start doing a lot of bandage, you're going to have a lot of emergencies and a lot of drama. So always good to start with the removable, explain compliance to the patient and parent, and explain the upgrade fee process if they need to upgrade to banded. I usually recommend charging an additional maybe $200 to $300 per arch if they are non-compliant and they need banded. Of course, if the parents are adamant that they want banded and not removable, that's fine. You can start there. Of course, you're not going to charge that upgrade fee, but you let the parents know there's going to be a lot of food restrictions, and if there's multiple breakage or emergency appointments, there may be additional fees for that. Usually, like I said, this is just a way better experience for everyone. There's almost no 8, 9, 10-year-olds, 7, 8, 9, 10-year-olds that I can't get to be compliant, assuming that I get a pretty good vibe initially when I get to know the parents and the kids, see how the dynamics are going. I'm looking at lots of things on the kids. Is the kid brushing her hair, brushing their teeth, trimming their nails? How's the skin? How are they dressing? Are they generally a compliant child? And how is the relationship between the parent and patient? Is this something, if I give them something simple to do, which is just putting this in your mouth and wearing it during the day, taking it out during lunchtime, putting it in a case and brushing it, are they going to be able to do this? And if I see a patient that comes in who's disheveled, unwashed, unbathed, can't handle basic hygiene, then no. Matter of fact, I might not partner with them at all, or I might wait till they get a little bit older. So just things to think about. So anyways, I digress. So you can get some expansion in these type of pediatric, what do we call them? Biotrainers. You can get maybe 2 to 3 millimeters max. But if you're really looking for dramatic expansion, you really got to go with the expanders. For me, I like to go slow and low unless there's some urgency. And it really depends on the frequency of turns, really will depend on the age of the patient, the skeletal maturity of the patient, what our objectives are. Usually maybe 2 or 3 turns. On a removable per week, maybe a little bit more on a fixed. Total turns will depend on how the patient responds. You have to keep a close eye on it. Of course, don't want to overturn. You want to make sure the patient's coming back regularly every 2 to 3 weeks or 3 to 4 weeks in your office to be checked. You're checking a bunch of stuff. We can talk about what that looks like. So, I had one patient that they basically ghosted. They disappeared. They hadn't expanded and they were just cranking it like crazy. Of course, there's a limit eventually to how much it cranks, but they totally blew the bite, we lost control of them. We tried to get a hold of them. We were sending them letters and certified letters, but you really don't want to be partnering with parents that you don't have a good connection with, because you are basically breaking the patient's jaw. It's not fused, so it's not broken, but you're, distracting it. And things can happen if it's done incorrectly. So you don't just want to be doing this, out of control. Okay, so more things. You can bling out these expanders in a variety of different ways to control habits, tongue position, tongue thrusts. You can also straighten teeth by putting all kinds of little screws and pistons in them. There's so much cool stuff you can do. The cool thing is that if you expand patients when they're young, with these kind of $100 to $200 expanders, and just let them be, the teeth actually come up, usually quite ideally to begin with. They don't come up crooked because you made space for them, assuming you're doing this before too many teeth are in, when the patient is 6, 7, 8, 9, maybe. Not when the patient's 11, that's not going to do much. You're going to have to do braces too. A lot of times if you do this really young, you don't even need braces. Or if you do, the need is like not need. It's a want. It's not a need. It's just aesthetic. So that's pretty sweet. And you can take a case from a 2-year braces case with extractions down to a 3-month clear aligner case, just because you made space at the beginning, and it ends up being way cheaper. Again, more cool ways. I mean, you can make these things really fun. If you're going to put all kinds of bling and glitters and decals in them, of course, it's going to cost a little bit more. This is an expander here as well, but this is also an expander that it works similar to the Invisalign MA appliance. As a matter of fact, this is the original Invisalign MA appliance. This is a twin block. So it's going to advance the mandible, help grow the mandible, as well as correct the jaw. And the bite. So that's pretty cool. I mean, what type of 7, 8, 9-year-old girl would not want to wear this to school? They trust me. They all want to wear this to school. That's really cool. So, again, more different modifications. This one you can use, and this is an older kid, so you're using it at the same time as braces. This is a fixed appliance, but it has acrylic on the posterior teeth. This is like caries waiting to happen. You have to have a really great patient. You got to have a really close eye on this, but this would be really great for a patient who maybe had an open bite or a habit, an open bite, because this is going to help to close an open bite. All that acrylic on the posterior teeth intrudes the posterior teeth, closes down the bite. So, and you can make the opposite for a deep bite. So many cool things you can do for $200.
So today we're going to be talking about expanders in general, and it doesn't matter whether this is a fixed expander, a metal expander, if it's cemented to the teeth, if it's removable. This is a removable type. It actually comes in and out. Let's just pretend like it's all the same, really. So this is a standard upper expander. You can see here there's 2 holes, okay? There's a top hole and a bottom hole. When we put the key in, we're going to want to put the key in towards the top hole. By top, I mean the hole closest to the front teeth, okay? Now, there's all different ways to kind of do it incorrectly. And unfortunately, if you do it even a little bit incorrectly, it doesn't work. So I'm going to try to show you the right way to do it. And then I'm going to show you some of the wrong ways to do it. And hopefully, you'll get the hang of it. It takes some time. So put your key in the top hole, the one closest to the front teeth. Okay. Not in the bottom hole. So let's go ahead and do that right now. Now, one of the keys, or one of the key points, is you need to make sure the hole is clean. So if it's not clean, make sure your child brushes it first, and you put the key in, and then you're going to go ahead and turn it towards the middle of the mouth, towards the palate. Okay. So I'm turning it until a new hole comes up. Can you all see the new hole? And it needs to be a full new hole, not a half new hole, a full new hole. Then when you pull it out, you want to pull it out. I usually use another finger towards the middle of the mouth. Make sure you don't rock that turn back. Make sure the new hole, the full new hole, is still there the whole time. There you go. So watch this. Boom. Take it out. Sometimes it's tricky. You don't want to stab the patient. But see, my new hole is still there, and you can double check it. Make sure it's still there. Make sure it's a full hole. You should be able to put your key in. Yes, I can. And you're done. That is your turn. Now, the actual amount of turns that you want to do is prescribed by your doctor. You cannot decide, because it really depends on the skeletal maturity of the patient, how fused the palate is. There's so many dynamics and variables that goes into picking how many turns and how frequently you do the turns. So I'm not going to tell you that. It is a special algorithm just for each patient. And if you overturn expanders, very, very, very bad things can happen. Okay. If you underturn expanders, so what? It takes a little bit longer. So listen to your doctor and make sure you're coming regularly for your appointments. Don't keep turning if you haven't seen your doctor as requested. That's my key for you. You don't want to be in that situation. So, okay. So I showed you how to do it correctly, how not to do it. So how not to do it, of course, would be to do it the inverse way, to do it backwards. That would be making your palate smaller and not bigger, right? Another way to not do it is to turn it halfway, or to turn it down, and then when you pull it out, to rock it back up. So basically, you're just going like that, back and forth, back and forth. You're seesawing instead of doing the full turn. So what should it feel like after you do your turn? After you do your turn, it's likely going to feel like a lot of pressure. So sometimes it's good to do your turn at nighttime, right before bed, after child's brushed and flossed their teeth. sometimes if they're a sensitive child, you may want to give them some normal Motrin, ibuprofen, whatever your pediatrician recommends that you take about an hour before the turn. It's really up to the child and how you're feeling. Pretty much that's it. You do your turn and then you wait until the next turn is supposed to happen. So, and most likely you'll be coming back regularly to visit your doctor to check on the turns. They're going to be checking all different things to see how the turns are going. What's normal to see, if the turns are actually going right and you're doing everything correctly, you should see a gap forming in between your front teeth. Now, if you had crowded teeth to begin with, you may not see a gap in that case, but that's normal because your arch is getting wider. And if your arch is getting wider, right, gaps are forming. You're making more space for the teeth to fit in. So that's great news. So anyways, that's pretty much it. And generally these expanders stay in for at least a few months, to go ahead and maintain the width of the arch so that it doesn't relapse. So that's my tip about removable Schwartz type plate expanders. But like I said, fundamentally, it works similarly to a fixed expander. Fixed expanders do often work a little bit quicker. But there's pros and cons to each one, and your doctor will pick the right expander for you.
So this is kind of your standard mini fixed expander. When would I use this? I would use this in a patient that was not yet skeletally mature. Remember how we find out about this? There's many different ways to, find out about skeletal maturity. In boys, of course, you're looking for signs of puberty being completed, like facial hair, feet are done growing. What else? Obviously voice change and Adam's apple. Those are the 4 things I ask about. This should be a really comfortable conversation to have with the parents and the kids, and it's often quite obvious, so sometimes you don't even need to ask. For girls, it's a little bit more of a sensitive conversation. Remember, for boys, the age could be anywhere from 11 to 17. Average maybe 12, 13, 14. For girls, it could be anywhere from age 9 to 14. Average is probably, and it depends on your demographics, is probably 11, 12 or 10, 11 even. So for girls, it may not be as a parent. You're going to have to ask those questions about when menses began. And it's a sensitive question, but it's important that you explain the why behind it, because if you're trying to do expansion or growth modification on a patient that is skeletally done growing, it's really probably not going to work. So that's why you need to know. So if somehow you can't get that information for whatever reason, and I don't see what not, or if the answer is no, they're not skeletally mature, but you're trying to figure out what type of wiggle room you might have, another great idea is to take a hand wrist x-ray. You can do that on a regular Ceph plate. And there's some give and take in learning how to do it. But if you do take a good hand wrist x-ray, I can teach you how to interpret it. It's very easy to read the growth plates. So anyways, back to our expander here from Specialty Appliances. This is a standard mini expander. It also has soldered face bow hooks on it. These face bow hooks can be used for protraction face mask or advancing the maxilla in a growing patient to jump a crossbite. They're fantastic. It's really easy. Check out some of our previous videos. But today we're talking a little bit more about how to turn the fixed expander. So remember, always look for the arrow, and there should be an arrow on it, and it's really hard to see. The arrow is pointing down here, okay? This 12 tells you, well, if I turn it over, you can see the 12 better. This tells you the size of the expander, how much width you can expect maximum. You're not going to turn it that far, but there's usually 7s and 12s, and they'll try to probably fit the biggest one they can get in. But if you have a preference, you need to let them know. Okay, so see the arrow going down, right? You see it? Oh, wait, it's going that way. Okay, there we go. So you want to make sure you put your key in the top hole, okay? And there sometimes could be more than one hole showing, and you want to turn it in the direction that the arrow says to go, okay? And sometimes when you try to get your key in, there is some gunk in there, actually more than often. Okay, you can see I put my key in, okay? This is my favorite kind of key. This is the swivel key. I would recommend you order these. It may not always come with your case, and I would always have extras because the patients will lose them. They cost like 50 cents. You can get them on eBay or at any orthodontic supply company. So put your key in the away or in the direction where you can turn, and then you're going to go ahead and do the full turn, okay? Do the full turn until you see a new hole come up. Can you see the new hole? The full new hole. Okay, this is the key. When they pull this out, remember, this is the patient's laying down, so this is a little trickier and it's kind of dark. So someone needs to be holding a flashlight. You have to have a bright light. When you pull the key out, the new hole should still be there. See it? And if they're not sure, because you don't want to rock it back, then you should put your key in the new hole and make sure that you can put your key in the new hole, which I can. I just did. So anyways, that's the trick for the expander. And I would definitely have the parent practice it outside the mouth. I'm going to roll this turn back now, just so we have it ready to go again. But I would definitely have the parent practice outside the mouth before you glue it in. And then have the parent do the turn in the mouth while you are still watching it. Now I'm rolling it back. This is not the way to do it, okay? And different expanders are going to turn different directions, so you just have to follow the arrow is the main thing, okay? So again, follow the arrow. When you do the turn, make sure the whole new hole comes up. If it's occluded or full of gunk, they might need to use a toothpick or clean it out to make sure they got the whole new hole. And when they take the key out, the whole new hole should still be there the whole time. Don't rock it back, okay? Frequency of turns is going to really depend on the age of the patient, what goal you're trying to get, how skeletally mature they are. So some people are turning once a day. For this fixed one, obviously Schwartz's are removable and they're going to be a lot slower. Some people are turning 3 times a week. There's a whole algorithm that goes with that, and it's not something that I can probably do on a webinar. But if you're working with us at StraightSmile Solutions, we'd be glad to explain more on how you do this. And remember, risks, if you turn too fast, too frequent, or on a patient that's skeletally mature, there's all kinds of risks that can happen. I've seen teeth go through the buccal plate. I've seen loss of vitality of teeth. I'm not saying I did this. These are ones I've seen other people do. And all kinds of really scary things, as well as just blowing out their face and looking really bad. So let's pain, discomfort, hemorrhaging. I've heard of death, hemorrhaging out their eyeballs if you try to expand it too much. You need to make sure if you're using an expander, especially a fixed one like this, that you're doing this on a compliant patient. You have a good relationship with the parent. You do not want to let the patients go away for an extended period of time. You should be seeing these patients at least every 2 to 3 weeks during the active expansion time, if not every week, to check on many different things.
And today we're going to be talking about this. We're going to be talking about activating your Schwartz or sagittal appliance, how to deliver it, the first step in a series of presentations about doing this. We all know that expanding the arches is huge. We know that expanding the arches is really part of creating the airway and establishing airway in your sleep disordered breathing patients. We know that this can be an integral part of all orthodontic treatment. Pediatric dentists are doing it, general dentists are doing it, orthodontists are doing it. Everybody loves to expand arches, okay? So this is gonna be the first in a series. Just real quick, number one, this is a key. This is my favorite kind of key. This is a safety swivel key, okay? This is the only key you should use. Don't use the other ones. Order them, don't be cheap. Number two, this is a nice little Schwartz appliance. It's very pretty. So it's glow in the dark. I'm huge on glow in the dark appliances because the patients will lose them sometimes and it's easy to find them. But basically, make sure, number one, that you've taken a good impression. Make sure that it's not distorted. Do not send off a junky impression. Number two, when it comes back, make sure that the keyhole is fully, reversed back to the beginning point. Sometimes when it's going in shipping, it can open up a little bit. Number three, you want to go ahead and make sure you can deliver this appliance passively, that there's nice retention, adequate retention. If you can't deliver it passively, you're not going to be able to activate it. So start there. If there's a problem, then you might need to redo the impression. Maybe there was distortion. Maybe the patient has lost a lot of teeth since then. You might be able to work around it, but do make sure you can do that. From there, you might need to adjust the clasp. We'll do a separate video about adjusting clasp later, but let's start with just the basic passive delivery. Once you can get it 100% delivered passively with adequate retention, you're ready to rock and roll, and that will be our next step in the series of adjusting your Schwartz and sagittal appliance. As you can see, I have my 2 trusty pliers here. This is my 3-prong plier. Why is it called 3-prong? Because it has 3 prongs, right? And this is what I call a bird beak plier. There's a couple other names for this. I think some people call it like a 139 plier or something like that. But basically it has a square tip and then a rounded tip. So if you do not have these 2 pliers, I would not attempt to start adjusting retainers yet because you need both of those. All right, so we have 3 different types of clasps here. Okay, we have a C clasp, a ball clasp, and an Adams clasp. These are your three basic types of retainer clasps. When you make retainers or any type of orthodontic appliance, you can specify which clasps you want, but my suggestion, unless you have a specific reason, is to leave it up to the lab tech to select the best clasp. And you can tell them that. And if you don't, it's pretty much understood that they're going to select the best one for that case. Personally, this is not my favorite at all. I don't like these because they bend easily and get distorted and things happen. So this is definitely my favorite for mixed dentition, the Adams clasp. Pretty indestructible, hard to mess up, and they fit pretty well. Downside is sometimes the patients are going to bite on the clasp. There's not much you can do about that. If they do, they just need to get used to it. Ball clasps are great, but they break easily. So if you put one on, you want to have many because if you lose one, it's always good to have another one. But besides that, the only other thing you got going on here that needs to be adjusted is the labial bow. And this is totally adjusted wrong, the way this came on this model, or maybe someone was playing with it already. But this is definitely not, granted the teeth are chipped, not where it should be. So it's over adjusted. So, but today we're going to be focusing on these three clasps. So basically, in a nutshell, this is the way I adjust them, and everyone might be slightly differently. Do this. Woo! This one is tight. If I can get this. Whoa! Great fit. Orthodontic lab. There we go. Got it off. Okay. That's a great sign if it's tight. All right. So to adjust a C clasp, I just tighten a tiny bit right here. The main thing is the ball needs to be under the undercut. It cannot impinge in the gingiva. And when I try retainers in, the first thing I'm going to do is snap them down and check the gingiva and see if they are, engaged or impinging the gingiva at all. Because start there, okay? And once you're kind of out of the woods, then make sure it's seating fully. The acrylic needs to be fully seating. If it's rocking or anything like that, it's not ready yet for adjusting. So before you start messing with the clasp, you want to make sure that your retainer is actually seating and seating comfortably. Once you get it seating and it's a little too loose, then you can start adjusting the clasp. So this one's an easy adjust. This one's also a pretty easy adjust. You're just going to use your 3-prong, okay? And you're just going to tighten it just a tiny bit right there at the little bend, okay? And sometimes you need to tighten it here and here. Just a tiny squeeze, a little bit goes a long way. If you overdo it, you can either flip this around and do it the other way, or you can use the square portion of this to go ahead and loosen it. And you know what? You're just going to need to play with it to try to practice it. But, in a nutshell, it's something like this, okay? To tighten, like this, okay? To loosen, you could either do like this, or you can flip it around and do like this, okay? All different ways, no wrong or right way. With the Adams clasp, I always start adjusting closest to the acrylic, okay? And if you're trying to tighten it, I'm going to squeeze like this and this, both spots, okay? If you're trying to loosen it, the opposite generally, okay? But remember, this will often interfere with the occlusion, but not a huge deal if it's in mixed dentition. So that's pretty much it. That's how I adjust retainer clasp. It's going to take a lot of trial and error for you to learn how to do this more ideally. As for the labial bow, that's a whole, it's a lot more challenging, okay? So, hopefully your labial bows are coming ideal for sure. And if you're using this just for a functional appliance for ortho, it's probably not a huge deal at all to have the labial bowl, contacting and ideal. But if you're using it for actual retention,
Dr. Amanda with StraightSmile Solutions, and today we're going to be talking a little bit about habit appliances. And I want to thank Ian Withers from Bitesoft Enterprises for sending me these models that we'll be using today to discuss it. Just a friendly reminder, any questions that you want to join any of our other webinars or anything like that, please visit StraightSmileSolutions.com. We do have a really cool webinar coming up. I have 2 guests, Dr. John Julian and Mr. Luis Rivera. We'll be talking about cone beam CTs and the ROI in practices that utilize orthodontics. So it really blew me away the first time I saw Dr. Julian's lecture, so please make sure that you join up. It is going to be May 20th at 8 p.m. Eastern. There's only limit to 100 participants because we want it to be as interactive as possible. So make sure you visit StraightSmileSolutions.com/media to go ahead and register while there's still seats available. All right. And also, please don't forget to visit our media page as well to sign up for our hands-on digital classes. These are customizable classes that you can do on your own time for a very reasonable cost to learn straight wire, to learn all different aspects of orthodontics. You'll have one-on-one customizable interactions, feedback, accountability loops, and everything like that. And this will save you a ton of money not having to travel to take a hands-on course. So do make sure you sign up. These are one-on-one courses just for yourself and or your team. All right, so let's dive into habit appliances. There's all kinds of habit appliances out there. These are not ones I would use on little kids. These are ones I'd use on older kids. So I'm going to say 7, 8, 9, 10. If you're trying to get some interceptive orthodontics done, maybe control some habits before jumping into actual phase 2 ortho or comprehensive ortho, that's a really smart idea. This one is not that pokey. I'm not a huge fan of these rake ones, but you know, if you have to do it, you have to do it. But at least it's removable. But I really love the colors and everything like that. There's also fixed versions. This one is not pokey. You can see it's more of a tongue crib to keep the tongue from going forward. It's a little more patient friendly, but it's definitely fixed in there. So that's a really sturdy device right here. And remember, these can all be ordered from my friend Ian. I think it's ian.withers@me.com. He does have distributors in the US and abroad. He does a really fantastic job on his appliances. They're just super high quality. This is what I'd call like he called it something else, but I call it a bluegrass appliance. It's basically a little like bead that spins and the patient plays with it with their tongue. I know that sounds kind of crazy, but what it does is it actually it tracks the tongue to the roof of the mouth to play with it because it's up there. It's something just to kind of fiddle with. But in doing so, you strengthen the tongue and you also increase that muscle memory so that the tongue that maybe has a tongue thrust will actually start to swallow correctly on the roof of the mouth. So it's actually a really great appliance. It's not mean or anything like that. Okay, what else do we have here? It's a little cut off here. But let's see if we can reposition this. This is actually a lip bumper, and a lot of patients do have lip habits where they suck their lip or they bite their lip. This is a fantastic, really kind, patient-friendly appliance. They can color it, have fun with it. It's very discreet. People won't notice it very well to go ahead and decrease that lip habit. What else we got here? We got one more appliance here, and there's so many different options. This is just another version of it from the front for the lip sucking habit. And usually if you're sucking lip, it's usually the lower lip. So anyways, those are my 5 habit appliances for you today. Don't forget about our digital courses and our free webinars. Please visit StraightSmileSolutions.com. And as always, if you have any questions or concerns, email us, info@StraightSmileSolutions.com. All right, have a great day.